You mentioned the American Heart Association. I know Dr. 𝙎𝙬𝙎𝘎𝙎, my friend, calls them the biggest fake news organization in America. That's her words. They just came out with an article. I don't know if you saw it on intermittent fasting increasing your risk of cardiovascular disease by, I think it was like 91%.
Yeah.
Did you look into that at all?
I just saw the headlines.
Okay.
I don't watch news, but I may have come across one of my social media feeds.
Well, it's an abstract, number one.
Yeah.
Number two, when I looked at it, Nathan, they're doing it based off of surveys. And most people do not remember what they ate and when they ate, first of all, and then what were they eating during their window, right? So it's such propaganda. It's so unfortunate that the American Heart Association is pumping that out there, and even prominent doctors as well pumping that out there, telling people that intermittent fasting will increase your risk by cardiovascular disease by 91%. What are your thoughts on intermittent fasting?
Look, I think the data on that are overwhelming.
Positively overwhelming.
Positively overwhelming. And so, there's always resistance when new data come out, and this isn't new data. Intermittent fasting, caloric restriction is probably, certainly stood the test of time in terms of mechanism in improving longevity, increasing longevity and health span. I don't know if anything that has the data to support it, it would be more beneficial. So, but the problem is now when you have when it doesn't meet the narrative, there's resistance. And then these big forces, whether it's AHA or American Medical Association, have to come out and defend that. Because the drug industry is $1 trillion industry. I mean, it's one of the world's largest economies in terms of the global economy. So when there's data that come out that infringe upon that, and you have to look at medicine, and my whole kind of philosophy changed when when you can't look at medicine as an altruistic practice anymore. Medicine is a business. It's a for-profit business. And the number one rule in business is never lose a customer. And when you look at medicine through that lens, you start to understand all the outside forces that are rebutting these studies. But to answer your question, caloric restriction, intermittent fasting, from cellular mechanism of action is very well defined, very well elucidated. And I think it's one of the things that improves lifespan and health. Everything that we know about longevity, from turning on mitochondrial biogenesis, having more mitochondria generating more energy to provide the cell and the body what it needs, improving telomerase activity, preventing the telomere shortening, and then mobilizing stem cells. All that, those are kind of the three cornerstones of longevity. And intermittent fasting through, induction of PGC1 alpha and all these important longevity gene pathways are turned on by that.
Yeah.
So I think, it's disruptive to what they're doing, and they have to rebut it.
Yeah.
So it's not surprising, but again, any objective person, and I have the benefit of spending 25 years in academia, reviewing the literature, being able to look at raw data, make my own interpretation. Because the data are data, right? Data don't lie. The problem is in a lot of these authors, like 𝙎𝙬𝙎𝘎𝑎, it's a misinterpretation of the data. And so when someone who with an objective lens can look at data and then make their own interpretation and not buy the interpretation of what the author or the program or the society or the association wants you to interpret, provide an interpretation for you, then that's the problem. We have to be able to look at the data ourselves, make our own interpretations, then utilize that data to make decisions that affect my life and the life of my family.
Well said. So don't fall for the headlines, and it's usually the opposite of what you're reading on mainstream on your social media feed. Let's continue the conversation on seed oils because we talked about it a little bit. It's called linoleic acid. That's the specific fat in these omega-6 fats. They're also called vegetable oils, and the reason they're so inflammatory is because of, number one, the chemical structure of them, right? They're polyunsaturated fats, so they have many double bonds that are closely located to each other. And they use really high heat temperatures to process them, the canola oil, the corn oil, the soybean oil. And then it goes rancid, so they put detergents in it to cover up the smell, and then they put other chemicals to make it more of a liquid or a clear liquid. They put it into a bottle, and then the American Heart Association puts their stamp of approval on it, and then we buy it, and then we heat it up even more. And linoleic acid in the body, in that mitochondrial membrane and cell membrane that you referenced, the half-life is 680 days. So if you stopped eating them today, and we'll give you a whole list shortly, about 2 years later, half of them will still be in your body fat. That's how inflammatory they are. So the list is canola, corn, and cottonseed, soybean, safflower, sunflower, and then rice bran and grapeseed. So those are the ones you want to avoid. Instead, like you said, healthy fats, saturated fats, monounsaturated fats, 1 chemical bond, saturated fat, 0 chemical bond. So butter, ghee, beef tallow, lard from healthy cows, coconut oil, olive oil, avocado oil. I don't know if I'm missing anything there, but anything else you want to add to that seed oil conversation?
No, I think your body incorporates what you give it, right? And so you can fool the body. If it doesn't have any natural fats, it takes what it is and incorporates in the membrane. The mitochondria has an inner membrane mitochondria, so those fats are even more important in terms of mitochondrial function. And you put one of these inflammatory or pro-inflammatory fats in there that disrupt the signaling, you're going to get disruption in the flow of electrons, develop mitochondrial dysfunction, and that's really the hallmark of every chronic disease.
Yeah. I think every health expert, they don't agree to a lot of things. Some experts say go vegan, some say do keto, but the mitochondria, I think they could all agree. You want to support the mitochondria.
That's where the buck stops.
Yeah, exactly. So if you could support, and we'll talk more about that as it relates to nitric oxide a little bit later. So when we go to dinner, and I've had dinner with you and Susan, we always tell the servers we're allergic to vegetable oils. And I created these seed oil allergy cards. So by the way, if you're watching or listening, you can get this for free over at seedoilcard.com. You just show it to them and you don't take the hit, 680 days. What would you say is worse in terms of what's going to accelerate disease faster? Eating a high processed sugar diet or consuming seed oils?
I don't know if there's any data on that, but I would predict that the sugar diet is going to accelerate it faster. Because everything that we know about normal metabolism and insulin signaling, glucose uptake, is completely disrupted by sugar. Sugar glycates, sugar is very sticky, right? So it'll stick to proteins. It sticks to the enzyme that makes nitric oxide. It sticks to a lot of enzymes. And so when these proteins can't change their structure, they lose their function. And when sugar molecules are bound to them, they lose their fluidity and they lose their structure, and most of them lose their function. So, and that's basically what hemoglobin A1C is, right? It's sugar stuck to the hemoglobin molecule. And it's not selected for hemoglobin, that's just one marker we can pick up in peripheral blood.
Good point.
So I would predict that it's, seed oils are probably going to be more chronically acting, but the fast onset, fast progression to cardiovascular disease, metabolic disease is sugar.
Yeah, it's a good thought process there. The A1C, there's a study that shows that if the A1C is at 7.5% or higher, every year it's at that number or higher, 100 days are taken off the person's lifespan. So essentially, I did the math. If it's at that level for 15 years, that's 4 years off the person's lifespan. That's how detrimental it is, to your point. So you want to make sure you master your blood sugar levels.
Well, it's not just that. You're losing 4 years of actual life, but what are you losing in terms of quality of life?
Yeah.
I mean, it's decades. You're going to walk around with diabetes, you got peripheral neuropathy, you're probably going to lose some toes or lower extremities, erectile dysfunction, high blood pressure. I mean, it's not just, for me, it's not about longevity, but living as long as I can, as healthy as I can. Nobody gets out alive, but what I want to do is if I live to be 120, 130 years old, I still want to be riding horses and roping and playing golf and going to the beach.
On.
If I'm in diapers in my bed, then I'll check out.
Yeah.
Thank you.
I want to see you when you're 120 riding your horses on your farm. I think we have a little bit of an age difference. I'll be there rooting for you, though.
Yeah.
The sugar creates advanced glycation end products, which attaches to these receptors for the advanced glycation end products. RAGEs, right? RAGEs. Share a little bit more about how that's depleting certain functions like collagen and just aging us at a cell level.
Well, the proteins, so enzymes are made up of proteins, right? They're proteins that have a catalytic function. So they're facilitating some biochemical reaction. And so most of them are metalloproteins. So it's always, as a biochemist, we count electrons, right? You have a source of electrons, and then they use these electrons as kind of an energy source. So we always look for a flow of electrons. And this occurs mainly through metals and then cysteine thiols. So cysteine thiols are sulfur-containing moieties on proteins. And so if you have oxidative stress, there's certain, then you oxidize those cysteine thiols and they become unresponsive. If you have a lot of oxidative stress, you'll oxidize the metal on these proteins, and basically render them dysfunctional. So what we have to do is maintain that normal redox balance. But if they're modified and there's certain modifications that turn proteins on, there's modifications that turn proteins off. There's phosphorylation, right, which is probably the sine qua non signaling mechanism that if you add a phosphate group, you can turn it off. So these are kinases and phosphatases. You put it on, take it off. And then there's controlled modification of that, like myrostylation. And there's different modifications. And then in the NO field, we have nitrosylation, where NO can bind to a cysteine residue, NO can bind to a metal, and then activate that enzyme, and then start this whole signaling cascade. But if these receptors or cysteine thiols are oxidized, then they no longer get the signal. If you have oxidative stress, you oxidize the metal in that enzymatic reaction or protein, then you lose its function. And you can do this through oxidative stress. You can do it through these advanced glycosylation end products. The sugar will bind to cysteine residues. It'll bind to tyrosine residues, different amino acids on those proteins. And now you've got a completely different tertiary or quaternary structure of that protein, and it's not going to have the same function. So all of this is really delicately regulated. And how do we post-translationally modify proteins to affect their structure and function? And when we lose regulation of that, which is what happens when we have chronic elevation of sugar and insulin, then you get these advanced glycosylation end products, and you lose enzymatic function. When you lose enzymatic function, the biochemistry goes awry, the cell becomes dysfunctional, and you get sick.
All in a nutshell. SAD diet. SAD creates ages.
That's exactly right.
Standard American diet creates advanced glycation end products. SAD equals ages. So is it all sugar? Because I think people watching and listening might be thinking, oh, but I'm having whole grains, I'm having the oatmeal, I'm having whole grain cereals. I'm not having processed sugar, but let's say it's the whole grains. Is it all carbohydrates in excess that this happens?
No, all carbohydrates are basically metabolized into sugar, right? And that's a very simple step. You don't have to do too many steps. But through the fatty acid cycle and different processes in the body, you can actually make sugar from fatty acids. So there's always a way to get energy. The body needs energy to do its job. So carbohydrates it's kind of the quickest step to creating glucose, which is probably the simplest form of sugar that the cell uses as an energy source. So any carbohydrates, whether it's grains, whether it's potatoes, and these are fruits, naturally grown fruits, it's fructose that's then broken down into that's a sugar source. But still, all of these can be broken down into sugar. So if a high fruit diet, I think Steve Jobs is probably the best example. Went on a straight fruit diet with very aggressive metastatic pancreatic cancer, and I think he survived less than 40 days.
Yeah,
you can't feed cancer cells metastatic disease sugar. That's how they respire. So I think the best way to do this, and everybody's metabolism is different, and I think that's kind of the latest rage on these continuous glucose monitors, because that gives you real-time data on what you're doing, how it's affecting your blood sugar. So you may be able to eat certain foods that don't see a spike in blood sugar or insulin, where I may eat that same food and may get a spike. And so that's what makes this so personalized, is that now we have the tools where we can measure the effects of what we eat and see because if you're seeing a huge glucose spike, then obviously you want to avoid that. So now there's no excuse. We have real-time monitoring where you can monitor your blood pressure, you can measure your blood sugar.
Even uric acid meters
uric acid.
At home, yeah. And they're coming out with a continuous ketone monitor, and there's going to be dual glucose and ketone monitors, which is super cool. You mentioned fruit. What's the difference between uric acid and the sugar, sucrose, glucose, and other sources of carbohydrates? What does uric acid do? Because most doctors will say, diabetics could have fruit because it's not going to raise glucose and insulin as much. The fructose isn't. But share a little bit more about how that's metabolized and the role of the liver there.
Well, this is the work of David Perlmutter, his book Drop Acid, where he talks about really the intimate connection between, mainly I think in his work is high fructose corn syrup, but it's really any fructose.
Even like fruit juice.
Any fruit juice.
Concentrated fruit, yeah.
Yeah. So through a very complex biochemical reaction, you start to see an increase in uric acid, and then uric acid affects a number of things, not just increased gout and kidney stones and things like that, but it completely shuts down nitric oxide production, which leads to the rapid progression of cardiovascular disease, high blood pressure, erectile dysfunction.
And Alzheimer's and dementia.
And Alzheimer's and dementia. So, everything is connected. The biochemistry that's inherent in the body is present in every cell, right? So if you have disturbances in normal metabolism, there's always consequences. And then things are going to, we talked about biomarkers early on, whether it's ferritin, whether it's uric acid, whether it's hyperglycemia, hyperinsulinemia. All of these are biomarkers and symptoms that, hey, you need to right the ship. Things aren't going our way. You're going to get in trouble.
Yeah, well said. And the liver metabolizes about 90% of that fructose. And what ends up happening if you keep consuming it, overwhelm that liver, becomes fatty, and then the pancreas becomes fatty, and other organs become fatty, and then you develop visceral fat.
Yeah, non-alcoholic fatty disease.
Exactly, which is an epidemic these days. Uric acid, you could test it at home. There are meters. One of the meters that when I interviewed Dr. Perlmutter, we spoke about that. 𝙎𝙬𝘎𝘎 on Amazon is a good one. We'll put a link for that down below. You want it under 6. Uric acid is transient, so I would recommend, just like blood glucose, you're testing it throughout the day. And this leads me now to, you're the master of nitric oxide, NO. I don't know if you get tired talking about NO. Yeah, hopefully not, because we're about to do a little masterclass. So if y'all watched or listened to the previous interview I did with Nathan, was about 6 months ago, that, you broke the internet with that video. you not only did that interview did really well on YouTube podcast, but the clips we extracted had millions of views on the clips. That was a really incredible interview that we did, all about nitric oxide. We're going to pick up from that conversation and go a little bit deeper today into nitric oxide. If you missed that episode somehow, we'll reference it down below. Go watch it. Layman terms, what is nitric oxide? What is it doing in the body? Let's start right there, shallow, and then we'll go a little bit deep.
Well, at its core, it's a signaling molecule. We've talked a little bit about signaling. It's how cells in the body communicate with one another. And so the interesting thing about nitric oxide is it's a gas. And it's one of the few gaseous signaling molecules in the body. So when it was first discovered, a lot of the scientific community didn't believe the fact that a gas would be a signaling molecule. Because prior to the discovery of nitric oxide and its signaling mechanism, we were taught that, there's this lock and key type signaling, right? So you've got a ligand and you've got a receptor, and it goes in and it fits in that exact spot like a lock and key, and then it turns that signaling pathway on. But there's selectivity and specificity when you do that, right? There's a certain receptor for that specific ligand. When it sees it, it activates. Well, nitric oxide's a gas, right? When it's produced, it goes everywhere. It diffuses in 3 dimensions, and it just goes right through cell membranes. So how do you dictate selectivity and specificity by a gas, number one, that diffuses in all 3 dimensions, and number 2 is gone in less than a second? So when it's produced, it activates its target, turns on these cell signaling cascades, and then it's gone. So you have to maintain normal and continuous nitric oxide production in order to get optimal cell signaling. So it was first discovered to be a vasodilator, right? So when it's produced by our endothelial cells, these are the cells that line all blood vessels throughout the body, that nitric oxide gas will diffuse into the smooth muscle that surrounds blood vessels, activate an enzyme called guanylyl cyclase. It's a heme protein. So nitric oxide binds to the heme pocket of that enzyme and then turns it on. And then it creates cyclic GMP. And then cyclic GMP is a second messenger that basically tells the smooth muscle to relax, mobilizes calcium, leads to smooth muscle relaxation. So it dilates blood vessels.
So it dilates the blood vessels, so it allows blood to flow more efficiently, oxygen to deliver to get to tissues more efficiently, et cetera.
That's right.
Prevents the blockage that you would see with arterial blockages that occur.
That's right. So we have a finite volume of blood, right? And if that volume of blood is going through very narrow blood vessels, you get an increase in pressure, right?
When the hose has a kink in it.
That's right. It's increase in pressure. And high blood pressure is the number 1 risk factor for the number 1 killer of cardiovascular disease. So we have to maintain normal pressure. So nitric oxide, by dilating the blood vessels, now you got that same volume of blood going through bigger pipes, so the pressure lowers. And so that was its first mechanism, a vasodilator. But now we understand that it's absolutely necessary for oxygen delivery. So not only are we dilating blood vessels to get more oxygen and nutrients to every organ, tissue, and cell in the body, but because of the what we call the allosteric regulation of oxygen delivery by hemoglobin, nitric oxide is required for hemoglobin to deliver oxygen. So if you can't make nitric oxide, oxygen won't come off hemoglobin. So not only will you not pick it up in the pulmonary circulation, but you can't deliver it. And so we saw this in COVID, right? People were developing hypoxemia, and their blood oxygen saturation would go to the 80s or 70s. You'd give them 100% oxygen, they wouldn't improve. You put them on a mechanical vent, they didn't improve, and a lot of people died.
Yeah.
Where all we did was give nitric oxide, restore the functionality of hemoglobin-based signaling, and now we could improve blood oxygen saturation from 76 to 98 in 8 minutes.
Wow.
Breathing room air. So we have to understand, number one, what are people doing to destroy their nitric oxide production? And then we certainly understand that. Now we've got to employ these strategies that will allow for the continuous production of nitric oxide. So you can dilate blood vessels, you can deliver oxygen, but we've also learned that nitric oxide inhibits inflammation. Some of my patents are on methods of reducing inflammation. We know that nitric oxide will mobilize stem cells. In fact, it's the signal that tells our own stem cells to mobilize and differentiate. So if you can't make nitric oxide, you don't mobilize stem cells, you don't repair and recover from injury. It turns on the enzyme telomerase, the ends of the chromosomes that prevent telomere shortening.
Which protects your DNA from getting damaged.
Your DNA. And it also improves mitochondrial biogenesis. So going full circle here, everything we know about longevity and living healthy and free of disease can be traced back to adequate nitric oxide production. And that's kind of the top. So it's foundational in terms of regulating all of these longevity genes and health and metabolism. But there are other things that may be going on, but what's clear is your body cannot and will not heal without adequate nitric oxide production. So we always start there and then start to do other things. Change your diet, get moderate physical exercise, eliminate seed oils, eliminate sugar, high carbohydrate diets. And then really the body does its job then.
Let's take a deep dive into what exactly it does. What are the mechanisms of action within the body and why it's so important to optimize our nitric oxide levels?
Well, it's a gas that's naturally produced in the body. It's produced in the lining of the blood vessels. It's produced in our brain. It's produced by our immune system. And so it's how cells in the body communicate with one another. It's most recognized as its ability to dilate blood vessels and improve oxygen and nutrient delivery to every organ, tissue, and cell in the body. So that's really the basis of what it is. It controls cellular respiration. It controls oxygen delivery to every cell in the body. It controls mitochondrial function, the number of mitochondria and the function of mitochondria in the cells. It controls and regulates the length of your telomeres, which predict longevity. It tells our own stem cells to mobilize and differentiate. So it's how our body recovers from injury and actually repairs and replaces dysfunctional cells. So it's really the holy grail kind of anti-aging medicine and longevity. So the problem is when you lose the ability to make nitric oxide, there are a lot of things that go wrong, right? You develop high blood pressure, you develop erectile dysfunction, you start to develop mild cognitive disorders, vascular dementia, Alzheimer's. You get a disruption in insulin signaling. You develop insulin resistance, type 2 diabetes. It's really everything we've learned over the past 30 years about the onset and progression of chronic disease all relate to the loss of nitric oxide production. It's the earliest event in the onset and progression of disease.
Okay, well, it's pretty much tied
what else you need to know?
Yeah, it's pretty much tied to everything is what I'm hearing. So let's talk about insulin resistance and type 2 diabetes because that's a large majority of my audience and my students that I teach. We know, I would estimate at least 60% of Americans are diabetic or pre-diabetic. Sure. Probably more, Nathan, because they're not really testing. They have no idea. But let's be real. It'll take 10 to 15 years before a person is even diagnosed with diabetes. In the meantime, they have hyperinsulinemia, big glucose and insulin spikes, and then 10, 15 years later, their blood sugars change. How does nitric oxide relate to that condition? What is going on if somebody does not produce enough nitric oxide? How is that creating insulin resistance and leading to type 2 diabetes? What's the mechanism there?
Well, it still is a very important question. And mechanistically, the scientific literature didn't provide any real evidence on how nitric oxide plays a role in insulin signaling and glucose uptake. So in 2009, we set out to kind of figure out what was the role of nitric oxide in insulin signaling and glucose uptake. So at that time, we knew that when you had a glucose spike or after a high carbohydrate meal, your pancreas secretes insulin. Insulin goes to primarily your muscle, liver, and adipose cells, and then starts this intracellular signaling cascade where it activates, PI3, AKT kinase, AMP kinase, which is the target of metformin. And then that would activate really the terminal process in glucose uptake, and that's GLUT4 translocation. So GLUT4 is a protein that's inside of most cells that when it gets the signal, it goes to the membrane and it binds glucose from the circulation and then pulls it out of the circulation. So it regulates blood sugar levels. But if GLUT4 doesn't get the signal and go to the membrane, then you don't get glucose clearance, you get hyperglycemia. Your pancreas senses it, so it secretes more insulin. You get hyperinsulinemia, hyperglycemia, and uncontrolled. That leads to insulin resistance type 2 diabetes and the systemic inflammation that occurs due to the hyperinsulinemia. So our question was, where, if anywhere, does nitric oxide play a role in that signaling? And what we discovered and published was that GLUT4, the signal that tells the GLUT4 protein to go to the membrane and bind glucose, is nitric oxide.
Oh, wow.
So there's 2 cysteine residues that are conserved throughout evolution, and it's the post-translational modification of those 2 cysteine residues that's necessary and sufficient for GLUT4 translocation, increased glucose uptake, and you completely overcome insulin resistance. So whether you're taking metformin to activate AMP kinase tells nitric oxide synthase enzyme to make nitric oxide, but if the enzyme is dysfunctional, it doesn't get the signal. Same thing with PI3-AKT kinase. It leads to phosphorylation of eNOS. If that enzyme isn't functional, it doesn't make nitric oxide. You get a breakdown in communication and insulin resistance. So we showed in that study mechanistically how nitric oxide works, and we could overcome insulin resistance type 2 diabetes just by giving nitric oxide and recapitulating that endogenous signaling mechanism. So now, I mean, it's even simpler now because we've known for decades that diabetes, type 2 diabetes, is completely reversible by diet and lifestyle. So compliance is an issue, right? Nobody wants to change their diet. Nobody wants to exercise more. But now we know if the mechanism of that is all on nitric oxide production. So if we restore nitric oxide production, we restore insulin signaling and basically overcome all the metabolic phenotypes of type 2 diabetes.
Why are so many people deficient in nitric oxide?
Well, there's, a number. It seems like the American lifestyle makes you deficient in nitric oxide.
and many things, nitric oxide being one of them.
And pharmacology.
Yeah.
So we understand that, a poor diet, a high glycemic diet, leads to glycation of the nitric oxide synthase enzyme, just like it glycates the hemoglobin in terms of hemoglobin A1C. We know that lack of physical activity and movement, you lose nitric oxide, develop endothelial dysfunction. Things like mouthwash use. We published years ago that if you use mouthwash, it kills the oral microbiome that are responsible for making nitric oxide. You become nitric oxide deficient, your blood pressure goes up, you develop erectile dysfunction, a lot of bad things happen. The other issue is drugs like proton pump inhibitors or antacids. These drugs have been shown to completely shut down nitric oxide production.
And people are popping them like Skittles.
These drugs were never approved for long-term use by the FDA, only acute use. But yet you've got people taking these drugs every day for 5, 10, 15 years. You got over-the-counter antacids now. And in 2015, it was recognized that these drugs, people who had been on PPIs for 3 to 5 years have a 35% higher incidence of heart attack and stroke because of the shutdown in nitric oxide production. Just last week, there was another study out that people who had been on these drugs for 3 to 5 years have a 40% increase in vascular dementia and Alzheimer's.
Jeez.
So these drugs are extremely dangerous. They should never be used chronically. They shut down nitric oxide production and cause the onset and progression of heart attack, stroke, and Alzheimer's. So those are and then fluoride is an issue because it's an antiseptic. It's in toothpaste. It's in municipal water supply. Those are the biggies. And then cholesterol-lowering medications used chronically disrupt kind of the lipid rafts in the membrane and disrupt cell signaling. They're mitochondrial toxicants. So it's really the improper diet, improper lifestyle, and standard pharmacotherapy all lead to disruption in nitric oxide production.
Let's tackle each of those. Let's start with diet. You mentioned eating a high carbohydrate diet. The average American consumes 300 grams plus of carbs per day. And Nathan, they're eating it throughout the day, all day long, pretty much. Grazing. They're grazing. And we're not designed to be grazers. We're really not. So they have glucose response, insulin response, up and down, up and down. That's depleting nitric oxide, as you mentioned, because of these advanced glycation end products. So the first step is to eat more of a keto or a lower carbohydrate approach and get rid of the snacking is what I'm hearing.
Absolutely.
Okay, so that'll take care of nutrition. Mouthwash. When you say mouthwash, do you mean all mouthwash or the ones that are the standard ones, the Listerines, the one that might have fluoride? What about the mouthwashes that use things like tea tree oil, oregano, different natural antimicrobials, coconut oil, etc.?
Yeah, there's a lot of things we don't know, so I'll tell you what we do know.
Okay.
Stringent antiseptics, things like chlorhexidine, the prescription antiseptic that's used for chronic halitosis, periodontal disease, a lot of dentists use it. But we've also tested things like Scope, Listerine, the alcohol-based mouthwash, the ones with fluoride. These products do exactly as they're advertised. You see the commercials. Kills 99.9% of the bacteria in your mouth.
Good and bad.
Good and bad. And it turns out that it's actually a really bad thing. So when you disrupt the oral microbiome, it shuts down nitric oxide production. We published, I believe it was in 2012, that if you use mouthwash, your blood pressure goes up. I was on the doctor's show several years ago revealing that if you use mouthwash, you lose the cardioprotective benefits of exercise. So think about this. You try to do all the right things. You try to eat a good diet. You try to get moderate physical exercise. But if you use in mouthwash, you eliminate the entire cardioprotective benefits of everything you're doing. So, there's a reason we don't take an antibiotic every day for the rest of our lives, because of the disruption in the gut microbiome.
It's like dropping a nuke. It'll take care of the bad guys that we want to get to, but also the civilians that...
Yeah, it's collateral damage that causes systemic... It wreaks havoc on the body. The microbiome, the bacteria that live in and on our body, outnumber on cells 10 to 1. Mm-hmm. So we eradicate those to our own demise. So we have to maintain a healthy microbiome. So why would anybody kill the oral microbiome every day, sometimes twice a day, for the rest of their life? There's 200 million Americans that use mouthwash every day. There's 200 million Americans with an unsafe elevation in blood pressure. Now we know that it's not coincidental. It's causal.
Interesting. Yeah, that is a huge correlation right there. And not just correlation, you have studies to back it up. Yep. You mentioned exercise. What are some of your favorite... A sedentary lifestyle is going to be problematic. So let's talk about specific exercises that have been proven to instantly raise nitric oxide.
Well, we know that aerobic exercise, so when we, can just... Number one, you need oxygen to make nitric oxide. Number two, you need nitric oxide to deliver oxygen. So there's a balance in how we exercise. So the data tell us that 20 to 30 minutes of aerobic exercise, getting your heart rate up to, say, 120, 130 beats a minute for 20 or 30 minutes, that provides the aerobic capacity and sufficient oxygen to where it stimulates nitric oxide production and improves endothelial function. When we reach that anaerobic threshold, then we run out of oxygen, we can't make nitric oxide, we go into anaerobic metabolism, we get lactic acid buildup, soreness, recovery is poor. So if we can maintain some aerobic capacity, we stimulate nitric oxide production, and then that improves exercise performance. So that's one, and it's just, I think the data are very clear for hundreds of years now that that's a cardioprotective and healthy way of doing things. The other thing I like is resistance exercise. Because when you're constantly contracting muscles and putting resistance, it not only makes your bones stronger so you don't develop osteoporosis, but it leads to what's called intermittent hypoxia or intermittent ischemia. So when your muscles contract, they're squeezing the blood vessels, so there's a period of intermittent hypoxia or ischemia. And then when you relax, you get blood flow. And this intermittent hypoxia has been shown to what's called ischemic preconditioning. So it preconditions that tissue from injury. And it does that because it's kind of like a part of hormesis. It's an intermittent, kind of a brief insult that then tells that tissue, hey, I don't want to run out of oxygen again. I need to make more nitric oxide, create some more collaterals, create vascularity, increase blood flow. So I think what the data tell us is, and this is what I do personally, I do 20, 30 minutes of cardio every day. I try not to get my heart rate up more than 130. So it's a light.
Specifically for those workouts to get the nitric oxide. Yeah. But does that mean you're never getting your heart rate up over 130?
No, so here's what I do. I have kind of a different protocol every day.
Okay.
So typically I'll start out with 20 or 30 minutes of cardio, just kind of burn calories, burn the sugar. And then I'll do 20, 30 minutes of resistance weight training. And then typically 2 to 3 times a week I'll do, and it depends on timing, right? Because we're all busy and we have to make time to exercise.
And you're traveling all the time.
But I will do, a 10 to 15 minute high intensity interval training, where I push my body to reach that anaerobic threshold, and I go to fatigue, I recover, and then if I have 10 to 15 minutes, then that is a little bit more abrupt kind of insult. But I think the data are clear in terms of remodeling and the ability to make nitric oxide. So I think we have to integrate all that and really prepare our body for anything that we encounter in life.
Yeah, that makes sense. You mentioned hormesis, which is something I think we should view everything we do in that lens of hormesis. Is it a positive stress or is it a negative stress, right? So hormesis is the principle. If it doesn't kill you, it makes you stronger, essentially, right? So some exercise and you adapt, great. You get that nitric oxide boost, you recover, you get stronger. Too much exercise, you get the opposite effect, that hormetic ceiling we want to continue to raise. I know cold exposure is a great hormetic stress as well, and it's very popular nowadays. I think a lot of people hear about cold exposure and the popularity of it. Wim Hof talks about it. You have these cold plunge coaches or whatever they're called, and I think a lot of people do too much of it, where they actually feel too wiped out the rest of the day. Their mitochondria didn't adapt. But let's say somebody is finding a good sweet spot for cold exposure. They're feeling more energized. What's happening with nitric oxide there? Because I know it's very similar with the blood flow going to your vascular system, going to your organs, and then being flushed out to your extremities. So is that a good way to boost nitric oxide as well?
You know, I'm not aware of any data looking at cold exposure and kind of the upregulation of nitric oxide production. But I think it's all about regulation of blood flow, right? So when you're exposed to cold and you get in an ice bath, it's basically shutting down the blood supply to the extremities because you want to conserve heat. That's how our body responds.
The innate intelligence doesn't care about losing your fingers, but it wants to.
So it basically internalizes your circulatory system so you don't lose the radiative heat from the cold exposure. And then when you get out, obviously your ability to respond and dilate blood vessels and restore blood flow to those areas that have now been hypoxic due to the cold exposure for, 2, 3, 4 minutes, whatever the cold exposure time is. But I think people have to be careful. You know, there's some people with underlying health conditions, they shouldn't push their body to these extremes. I mean, so we have to be very careful. I think in terms of inducing hormesis and creating that brief insult that your body can adapt to, right? Because it's an adaptive response. Our body, we're exposed to this kind of shock, and then our body goes, oh, I need to prepare for that. So it undergoes these adaptive changes. We improve mitochondrial function, the number of mitochondria, energy production, and the regulation of blood flow. Mm-hmm. So in general, that's how the body works in terms of adaptation. But I'm not aware of any studies that have looked at nitric oxide production specifically as it relates to cold exposure plunges.
It would be fascinating. And, ketosis is similar, a mitochondrial biogenesis and what it does, because it's kind of a stress. Your body thinks you're going through a famine. That's why I love keto short term, but not long term, because there's that hormetic curve that drops. When you mentioned cholesterol, and I think this is a very interesting topic, because you said that, I think on the last episode, that you're more concerned if somebody has a total cholesterol of less than 200 versus somebody who has a higher cholesterol. Explain that and what it does to block nitric oxide.
Well, cholesterol, our body makes cholesterol. Mm-hmm. And so our body doesn't make mistakes, right? If our body needs cholesterol, our body's going to make it upon demand. And so we get cholesterol from the diet, and we also get it through endogenous production. Cholesterol is also the backbone for things like testosterone, estrogen, vitamin D. So if our cholesterol gets too low, we can't make hormones or vitamin D. And we have a global epidemic of testosterone deficiency in men and hormone imbalances in women and vitamin D deficiencies.
Yeah, and vitamin D, correct.
So our body heals itself, right? Our body senses what's going on and then self-corrects. But if we have a drug that inhibits endogenous cholesterol production, which is what a statin does, then our body can't respond. So if it senses that we're not getting enough cholesterol or that we need to make it, then the body can't. And the consequences of that are obviously obvious now. Because these drugs have been on the market, 25, 30 years. There's data showing that there's a higher incidence of type 2 diabetes. Some data coming out now for vascular dementia and Alzheimer's, even cancer, because they're mitochondrial toxicants. And when we talk about cell signaling, which I'm a biochemist and physiologist by training, so when we look at extracellular binding and then intracellular signaling, it's the integrity of the membrane, which is made up of cholesterol and fatty acids and a lipid bilayer. If there's not enough cholesterol in there, you lose the membrane fluidity. Mm-hmm. You lose this communication between the outside of the cell and the inside of the cell. And then the cholesterol acts as like an insulator, a capacitor that maintains the transmembrane potential. So a normal cell operates at minus 25 millivolts, which is, if you use the Nernst equation, it's a pH of 7.4. That's the potential of a particular pH. If you lose that transmembrane potential and that capacitor effect of the cholesterol, then you lose that transmembrane potential, you lose all the intracellular signaling, and bad things happen. And it does this because a lot of the intracellular proteins are connected to the extracellular ligands through this transmembrane protein. If you don't have cholesterol in there, that protein complex falls apart, and now you've lost signaling from outside to inside. And that's really, truly a disruption in cell signaling. And so we have to have cholesterol to do that. And if we're getting our cholesterol below 200, which seems to be the standard now, or the standard of care,
On that note, real quick, my fiance used to work for a company, a corporate company, and they used to reward their employees for the person who has the lowest amount of cholesterol. They used to get a bonus.
Well, maybe it doesn't surprise me, but I think it's the biggest myth that's ever been perpetuated in the medical sciences. Cholesterol does not cause heart disease. 50% of the people who die from sudden cardiac arrest have normal cholesterol levels.
I know, is that crazy? Oh,
so why would we lower cholesterol when it has no bearing on the outcome of heart attack and stroke? Now, there's other things. We can look at kind of an advanced lipid panel. Total cholesterol, HDL, LDL have no bearing whatsoever on prognosis or cardiac risk. It's some of the lipoprotein particle number and size and the amount of oxidized lipoprotein that can really give us a sense of what's going on in terms of cardiovascular risk. But total cholesterol is pointless. HDL, LDL ratios are completely pointless. But yet, if you go to your physician, that's what they're measuring.
Yeah.
It has absolutely no bearing or prognostic value whatsoever.
And most of them are not looking at the particle sizes of the LDL. They're not looking if it's the small, more inflammatory type or the large.
And they think that lower is better, right? So the lower
They
your
do.
cholesterol, the better.
Yeah.
But they forget the basic biochemistry they learned in medical school. And I taught in medical schools for 15 years. We teach them biochemistry and physiology, then they learn pharmacology and billing and coding, and then they forget everything about biochemistry and physiology.
Well, that's
So we have
the
to...
brainwashing.
Yeah, the human body heals itself. We just got to get out of the way.
Yeah.
Physicians and drugs don't heal patients. Patients heal themselves.
Oh, so true. So just to recap what you said, for those who, you went a little bit deep there, so I want to just break it down. We have about 30 to 70 trillion cells, give or take, depending on how large the person is. Every cell has this lipid bilayer around it, the cell membrane, which I believe, and I think you do too, that's where the intelligence is, not the DNA,
sure.
right? That's where Dr. Bruce Lipton has proven. You remove the membrane, instant death. You remove the DNA, the cell still functions. So the membrane is the wisdom, and that's what's allowing good things in, nutrients, oxygen, thoughts, other amazing processes, and then bad things out, inflammation, reactive oxygen species. So with low cholesterol, it disrupts that permeability, makes it too rigid, or too permeable.
Well, you lose the fluidity of the membrane.
So the good things can't get in, bad things can't get out.
Yeah, but I think most importantly is you lose the transmembrane potential, because there has to be a charge difference, an electrical potential inside of the cell versus outside of the cell. Without that cholesterol, which acts almost like an insulator or capacitor to maintain that charge differential. Now, if you lose that, then cells they kind of switch their polarity. So now a cell will operate at a plus 30 millivolts instead of a minus 25 millivolts, which is a pH of about 6.4. So you become acidic, you're acidotic, your mitochondria become uncoupled. It's called the Warburg effect. And now you're setting the stage for cancer and cancer cell proliferation and growth.
What are the diet and lifestyle habits people do daily that are causing inflammation and disease these days?
Well, that's an easy question. All you got to do is look at what the typical American eats on a daily basis.
That's right.
And does. But, it starts with sugary food, simple carbohydrates. Basically, if you follow the government pyramid on dietary guidelines, you will develop metabolic disease.
So do the opposite.
Do the opposite.
Yeah.
Yeah. So look, it's sugars, it's carbohydrates, it's seed oils, it's processed food. It's basically getting away from what nature intended.
So let's start with the sugar and carbohydrates. The average American consumes about 300 grams of carbs per day. And not only that, they're eating throughout the entire day. They're constantly grazing. So you have this situation where glucose and insulin. And I would argue this is one of the first dominoes to fall, the high insulin levels that leads to insulin resistance and then diabetes. And then diabetes leads to a whole host of other issues. Explain more why sugar is so detrimental inside of the body. High levels of sugar, I should say.
Well, it's a fuel. So it's a combination of things. It's the diet. It's the high carb diet. If you're an athlete and you're burning, 3,000-4,000 calories a day, you need that fuel. But most Americans aren't, right? They get up, they eat their breakfast, they eat throughout the day, they get in their car, they drive to work, they sit for 8 hours, they go home, they eat again. As you said, they're grazing throughout the day. They're not burning any calories. So that has to go somewhere. So each time that they eat, they get an insulin spike, or they get a hyperglycemia and elevation in sugar. The body's natural response is, I need to get more insulin to get the sugar out of the body. And then, as you said, you get these spikes. And it's not the hyperglycemia that causes the damage. It's the hyperinsulinemia. That's the inflammatory cascade that starts this really very slippery slope to metabolic disease, insulin resistance, diabetes, and then all the cardiovascular related complications from diabetes. So, look, the science is very clear on what we need in terms of defining metabolism, right? Metabolism is basically using the food we eat to convert into energy. And everybody has different metabolic demands, depending on how active we are. And I don't think there's a one size fits all, right? We have to custom tailor our diets to fit our lifestyle. But what's clear is the typical American diet and lifestyle is dangerous, it's disease causing, and mechanistically we know why. So we don't need to do more studies, we don't need to advance the science, we need to apply the existing science and information into our daily lives, and that takes a discipline.
The sugar, when we talk about glucose and insulin spikes, I read a study, the Whitehall study, which showed that insulin resistance could be developing year after year after year, although the A1C, that 3-month average of the blood glucose, might not even shift for about 14 years. And at that point, then that hyperinsulinemia, those beta cells and the receptors for insulin are so burnt out, then the blood sugar shift dramatically, and then it's prediabetes and diabetes. So what are some things we can do? What are some tests we can measure now to ensure that we're not headed down that path?
Well, I think there are a number of tests. So our body always tells us things, right? We have to listen. So when we start to become metabolically challenged, so constant cravings is not normal. And typically that's the first sign of probably your diet is not right for you. But we start to get these inflammatory markers like hyperlipidemia, and it's not really cholesterol, it's really high triglycerides, which I believe is a marker of increased sugar consumption. Because we get fuel from three sources. We get proteins, fats, and carbohydrates. And each organ has a hierarchy of what, like the brain likes sugar, the heart likes fatty acids. So every organ has a preferential energy substrate that it likes to use. But you start to get metabolic disease when you overdo those, right? And really the problem is sugar. Because the cell always has a way to, break down fats into fatty acids, provide energy, or, worst case scenario, kind of the last line of defense, you start breaking down protein. But that's typically not the problem in the American diet because there's so much fuel from sugar that we never run out of substrate. But I think so in terms of the metabolic phenotype, is you start to get the ongoing hunger pains. That's why people graze throughout the day, and then that exacerbates the condition. You start to get, elevations in C-reactive protein because sugar is inflammatory, it's poisonous, and it causes a lot of metabolic disturbances. Hyperlipidemia, and then just fat deposition, the visceral fat deposition. You get the fat around the waist, which is probably the most inflammatory fat there is. And then people are tired all the time. Even they're consuming all this food, they're lethargic. It's because their body's overwhelmed. I'm constantly amazed at how resilient the human body is because
Same.
I see people abuse it and what they put in their body and what they do, and yet they're still alive. So the body is enormously forgiving, but there comes a point where it can't handle what you're doing. And you don't just wake up one day with diabetes, right? This is a constant chronic process, and your body's constantly telling you, hey, this isn't good, but people ignore it. And, medicine today is a reactive practice, and Americans are reactive, right? And their fear, they make decisions based on fear. And people don't make really life-changing dietary changes or lifestyle changes until it's too late. They've already had a heart attack, or they have diabetes, they've lost a limb, or they develop neuropathy, they have erectile dysfunction, and then people go, oh, well, maybe I need to change now. No, you needed to change 20 years ago or 10 years ago. Now you're really up on a very slippery slope, and it's much harder to reverse course at that point where, like you and I, we understand this and we're proactive. It's hard work doing what we do, maintaining a healthy lifestyle and eating the right foods because, we have to overcome temptations because we're constantly bombarded, whether it's, I don't watch TV, but when I did, the commercials, every other commercial is either a drug commercial or from big food, trying to sell you cereals or dangerous foods. But you have to have the discipline to make those decisions, make the right decisions, and your body will thank you for it.
Yeah, our environment is so important. You're right with the television. I think we discussed this. 75% of all TV commercials are funded by big pharma in the United States, and only 2 countries in the world allow for big pharma to market directly to the consumer: the United States and New Zealand. Only 2 countries in the world, and then the majority of the remaining commercials are big food, McDonald's.
Yeah. And they're in cahoots because the big food's causing the disease that the big pharma can now treat.
You said a couple of things very valuable there. Let's unpack. So for testing, looking at triglycerides, we want to see that under 100 would be optimal. Looking at maybe small particles, LDL, what's called pattern B. Looking at C-reactive protein, a good inflammatory marker. I would add on like a fasting insulin as well.
Yeah, absolutely.
Make sure that's in the single digits.
But ferritin's an acute phase inflammatory marker.
Yeah, tell us more about ferritin.
It's historically it was always used for kind of your free kind of labile iron stores. But iron's critically important in the body. I mean, we need iron in our red blood cells to carry oxygen. It's the iron of hemoglobin. There are many hemoproteins involved in important biochemical and catalytic reactions. But iron can also be damaging. There's something called the Fenton chemistry, where you have an antioxidant with a redox active metal, and you create this hydroxyl radical, and it creates this inflammatory oxidative stress. So you have to manage your labile iron stores. And so when ferritin gets up, then that's the problem. So, people can use it for diagnosis of hemochromatosis, but typically that's not a genetic issue. It's a response to your diet, and it's a metabolic issue. But it's certainly an acute phase inflammatory marker.
There are some people who think your ferritin should be as close to 0 as possible. What are your thoughts on that?
No, look, you can't. The terminal electron transport of the terminal step of the electron transport chain in the mitochondria is cytochrome C oxidase. That's a hemoprotein. So if you run out of iron, number one, you can't deliver oxygen. Your mitochondria can't respire. So we need an iron store. And I think we have to, I think phlebotomy is a good thing.
The fastest way to lower it is phlebotomy.
Getting rid of excess blood, so now your spleen and your system can make new blood cells. Bloodletting is a medical practice that's been used for hundreds, maybe thousands of years, right? From leeches back then to just normal phlebotomy and just bloodletting. So we have to renew. The human body is regenerative by nature. We just have to get out of the way, give the body what it needs, and the body does its job.
Yeah, amen.
The problem is we get in its way.
We do. You just flew here from Texas, so I'm sure you see on the airplanes what people are doing to themselves, right?
Are you going to have lunch with us today, Dr. Bryan? I'll pass things.
Yeah, same thing. The flight attendants love me because I'm just like, no, I have my water. Maybe I'll have like my beef jerky if I eat at all, but I'm not eating that airplane food.
No way.
It's like you see this chicken. It looks like this is actually chicken. What is this? So ferritin. Is there a certain range that you would like to be in personally that considered optimal? I know that it's different for men and women, and typically for menstruating women, they typically are losing blood each month, so they don't have high ferritin. I've seen men and postmenopausal women have higher levels of ferritin, myself included. Even though my diet is clean, ferritin tends to be a little bit higher for me. So is there a certain range you're trying to hit?
No, not me personally, but here's what I've learned. Medicine's a moving target, right? So what's so-called normal, within normal range, maybe normal, because how they define normal is kind of underneath the bell curve, right? As long as it's 2 standard deviations away from the mean, then that's normal. But if you want to be normal, that means you're like the rest of the American population, like 95%. I'm not interested in that. Mm-mm. So labs, thyroid hormone, for example, the normal ranges have shifted dramatically over the past 40, 50 years.
Because we've gotten sicker and sicker.
It's gotten sicker and sicker. So normal is not normal. It's common, but it's not normal. And that's a big difference. So I really don't pay attention to what's normal in a blood profile, because to me, that's not, I want to be optimal. And if normal means I'm like 95% of my colleagues and peers, then count me out. I'm not interested in that.
Yeah, same. It's interesting because the conversation on ferritin and stored iron and it being like a rusting sort of property inside the body. I always think about, why is the body raising it? Yeah, our poor diet could do it. Different factors could influence high ferritin levels. But when we think about our ancestors, the thought process is this: our ancestors had healthy levels of iron because they were bleeding through combat all the time, which, okay, that makes sense, but not all of them were bleeding through combat. So would you say the major culprit these days of high iron is our diet and lifestyle?
Yeah, look, there's endogenous systems that deal with iron, right? And how do you make, you can make a porphyrin ring, it's part of these metalloproteins that uses heme iron, or that uses iron as part of that heme pocket. And so as long as you have normal metabolic activity and enzymes that deal with iron flux and iron shuttling, then everything's fine. Your body always responds. So it's always a balance of production versus consumption and how that iron is utilized. But most importantly, it's not just iron, it's any redox active metal, because there's different redox active states of certain metals, whether it's selenium or copper
or heavy metals.
Or iron. Yeah, or heavy metals. And that's why heavy metals are toxic, because they steal electrons, right? They're electronegative and they oxidize other molecules. So I think what we have to do in terms of maintaining normal iron metabolism is we have to maintain a healthy store of iron to where you can call upon it if we need to make new red blood cells and incorporate and make new hemoglobin and increase the oxygen carrying capacity of the circulation. But you have to also maintain a certain level of antioxidants, because metals are typically oxidants based on the redox potential of that metal, and then you've got to provide that source of electrons through antioxidants to restore the activity of that metal, whether it's iron or selenium or chromium or copper or any metalloprotein.
The other thing that you mentioned was symptoms and how the body's always communicating to us, so these check engine lights. And it's so important to understand that symptoms are not the problem. They could be so far removed from the actual problem, but we've been brainwashed to believe they are the problem. So take this medication, do this surgery, let's hide it, let's mask it. But if your check engine light turned on in your truck that you have right outside my house here, then you would find out why. You would pull the car over, right? You wouldn't just mask and just keep driving down these Miami streets. Same thing with our symptoms. If you ate a whole bunch of crappy food one night, and then you wake up the next morning and you have acid reflux, GERD, you're bloated, and maybe have diarrhea. You talk to your conventional doctor through, let's say, a virtual consult that morning. They're going to hear you and say, here's 5 prescriptions for an antacid, anti-flatulence. But if the doctor would have just said, what did you eat last night? That was the cause. Don't do that again. Then that's the solution.
No, they're exactly right. And I use that as my guiding light, because if I eat something that's inflammatory and causes me distress, then the last thing I'm going to do is repeat that. And so I think people, and it's part of American culture now, is, you feel bloated, you have acid reflux and GERD and, gas. And people go, well, that's just, I can take Prilosec or Nexium and get rid of the antacids. I can take, Imodium or Pepto-Bismol, calm my stomach. And they keep doing it. And it's masking the symptoms, but these symptoms are telling your body that what you did is not good. It's like pain. Pain is a good thing because it tells you, hey, don't do that, right? If you put your hand on a hot stove and it burns you, it's good. Okay, don't do that again. So people who don't sense pain put themselves in danger. And so people who don't pay attention to symptoms put themselves in danger. They're not going to get burnt. They're going to die from cancer or cardiovascular disease. So we have to rely on the symptoms. And the check engine light is good. I like the red light when your iPhone or your smartphone gets dead. People panic. The red light comes on, they're about to lose charge. They'll do anything in the world to find a charger and an outlet to plug that in. But yet they'll develop erectile dysfunction. They develop metabolic disease. That's the red light coming on saying, hey, I need help here. And they ignore it until they have a heart attack, until they have a stroke, or until they lose a limb to amputation from diabetes. And they go, oh, well, I didn't know this was even happening. No, you have to pay attention to your symptoms.
Yeah.
It's your body telling you, hey, righten the ship or you're going to sink.
Yeah. Symptoms are feedback. Amen to that. So the first step is to lower your sugar and carbohydrate intake. The second step is to, pay attention to what the government's telling you to eat and do the complete opposite, right?
That's right.
The George Costanza effect from Seinfeld, the episode where he did everything opposite and got good results. You mentioned seed oils, and I talk a lot about seed oils. I actually have these seed oil allergy cards that we'll talk about. But why are seed oils so damaging to the body?
Well, fat's an essential nutrient that we need, and we need healthy fats, right? Every cell in the body is made up of a cell membrane, and the brain is 80% fat. And then every cell in the body, whether it's in the heart or the lung or the kidney or the brain, there's a cell membrane that has to have a certain amount of cholesterol, fat, fatty acids, lipoproteins that maintain not only the structure and the fluidity of the cell membrane, and that's what initiates the intracellular signaling. So there's one of the common transmembrane proteins is a 7-transmembrane protein, and that starts. So when something binds to the outside of the cell, it starts this intracellular signaling and tells that cell to do whatever, to increase GLUT4 expression and bind glucose, or to turn on nitric oxide production, or to induce mitochondrial biogenesis. So if we run out of fats or cholesterol, or worse, we have these fats from seed oils in there, then you completely change the fluidity of the cell membrane. The cell's not able to sense the outside environment because it's lost the signaling control for that, and the cell becomes dysfunctional. And then a lot of times it doesn't undergo programmed cell death or apoptosis. It just becomes necrotic. You create these zombie cells, and they're there and they become dysfunctional. So we have to avoid that, and we have to get natural fats, good fats. Fats were demonized, 30, 40 years ago?
In the 1950s. Well, that's 50s. Where it started with 𝙎𝙬𝙍𝙬, but in the 80s is where it really took off.
And then really trying to employ that into public policy and decision-making on foods. But, I think the verdict is pretty clear on that.
Yeah.
That eliminating fats from the diet is really a bad idea. Fats don't cause heart disease. Cholesterol doesn't cause heart disease. Statins were brought to market in, I believe, in the 90s. And at that time, maybe even the 80s, when I can't remember, the Nobel Prize was to Brown and Goldstein, was maybe early 90s. But the American Heart Association predicted that by the end of the 20th century, that cardiovascular disease would be completely eradicated, and the number of percutaneous coronary interventions, or PCIs, would be eliminated.
They said that?
They said that. The American Heart Association made a statement the day that the statins were brought on the market to eliminate cholesterol.
And what has happened since then?
Well, in 1980s, there was about, over a 6-year period, there were about 1,400 PCIs. And these are like angiograms or what we call stents now. And they said they would completely eradicate those by the turn of the century. So from 2016 to 2017, in a 1-year period, there were over 1,600 PCIs in the U.S. So for 6 years, there was 1,100 in the 80s. In a 1-year period, 40 years later, there's over 1,600.
Wow.
So it goes to tell you that, number one, targeting cholesterol has not done anything. In fact, it's made people more unhealthy, because now you see that chronic statin treatments leading to diabetes because you're eliminating the insulin signaling across the cell membrane, no cholesterol. You can't get insulin signaling or any type of cell signaling for that effect. There's an epidemic of low hormones, low estrogen, low testosterone. If you don't have cholesterol, you can't make hormones. There's an epidemic of low vitamin D. Vitamin D is built on the cholesterol backbone. Yeah. So when you get your cholesterol below 200, you develop low vitamin D, you become immunocompromised, you're susceptible to seasonal flu, any virus, any infectious disease. Then we've got an epidemic of low T and hormone imbalances in women. And people wonder why. It's no mystery. So I think medicine is well intended. I think there's too much influence from big pharma on establishing a target that they can create a drug for, rather than understanding the physiology and pathophysiology and going after that target, establishing that target. And that's the problem. I think that's where medicine has gone awry and led us astray over the past 40 or 50 years.
With the whole cholesterol story, it began in the 50s with that guy, Ancel Keys, right?
7-country story.
Which was really a 22-country study.
That's right.
But he cherry-picked the 7 countries which fit his hypothesis that the countries that consumed the highest amounts of cholesterol and saturated fats were the countries that had the highest amounts of cardiovascular deaths. And he did 22 countries, but only 7 of them actually met that hypothesis. But out of those 7, they were not even consuming saturated fats. They were consuming margarine and fake fats. So he lied and he duped everybody. He was really persuasive. And now we're dealing with that to this day. And the statin industry, I looked it up, they made $15.4 billion in 2023. So why would they want us to know the truth when there's a lot of money to be made from these statins, which obviously are not doing the things that people want them to do, the reason they take it? And maybe it is lowering their cholesterol, but they don't realize the whole cascade of things that happen when you actually lower your cholesterol.
Yeah, no, look, not only has it not impacted or reduced the incidence of heart attacks or the onset and progression of cardiovascular disease, it's inducing other issues like diabetes. These statins are mitochondrial toxicants.
Yeah.
End up causing cancer.
Congestive heart failure as well.
Congestive heart failure. You deplete CoQ10, your heart, you're losing a simple or a very important substrate for normal mitochondrial function. So it's not only, and for me, everything is about risk benefit. Any decision I make in life, whether it's, in this case, whether or not to take a drug or not, or whether to make any decision, what's the risk and what's the benefit? And if there's no risk and it's all benefit, then it's an easy decision. If there's no benefit and it's all risk, it's a very easy decision, right?
Yes.
And so with statins, and I put this through the rigor of kind of our scientific method, is what are the benefits? 0. What are the risks? Diabetes, cancer, myalgia. That's a short list.
0 benefits of statins.
0 benefits of statin. Like the cardiologist and the allopathic doctor will tell you, there's what's called pleiotropic effects of statins.
What does that mean?
So there's benefits of statins that are independent of their cholesterol lowering mechanisms. But I think if you look at, so there's 3 types of trials that are typically conducted on long-term medications. There's primary prevention. So you give this intervention to people that are at risk for developing a heart attack or some endpoint. And that's primary. So you treat them and see if it prevents a first heart attack. Then there's secondary prevention. There's people who've had, for instance, a heart attack, and then you put them on this therapy and you can prevent subsequent heart attacks. So all the primary and secondary prevention data on statins is awful. It doesn't prevent heart attack, a first event or a second event. But what they're saying is, and again, the data is very poor on this, but what they'll convince you is that if you have existing plaque, it kind of provides an anti-inflammatory property that will stabilize existing plaque. And I think it's complete bullshit, honestly. But it gives them another reason to prescribe, because you can't ignore the data now, right? Now, for 10, 15, 20 years, we've lowered people's cholesterol to 200 or better. Rate of heart attack, stroke, cardiovascular disease hasn't changed. In fact, it's gotten worse.
Yeah, number 1 killer in the U.S. and most
So then how do they keep
countries.
rationalizing or justifying the use of these drugs? Well, okay, for primary or secondary, tertiary prevention, we'll put you on these to help stabilize the plaque. But again, the data are very poor, so there's no added benefit, and yet the risks are compounded. So there's no, statins are a great example because we have 40 years of data on that.
Yeah.
And you can no longer ignore the data. Look at the data, look at the outcomes, and look at the risk that you impose by giving these drugs. And any physician with any common sense who reviews the literature and is going to do what's best for their patient cannot advise or give these drugs. To me, it makes no sense.
Are some physicians incentivized to prescribe a certain amount of statins? And do they get some sort of financial gain from that?
Well, they're not supposed to. Years ago, that happened.
I remember.
Yeah.
Is that not
and then
supposed to be
there
going
were
on?
laws passed where you can't be incentivized to do that. Now, it's not to say that it doesn't happen.
Right.
But I think here's the problem. I know a lot of good physicians and they're good people, they're good humans, and they're well intended. And then there's some bad, just like in any industry, there's some really bad actors. So it's not the doctors and the physicians and the practitioners that are the problem. It's the system in which they have to operate that's the problem. Because I know a lot of good docs who are going to cash practice because they can't do what's best for their patient within the confines of the standard of care. Because once you make a diagnosis, that physician has finite responses to what he can do for that patient. Because everything's coded based on diagnoses. So if you make a diagnosis of diabetes, for example, then you've got really a short list of medications.
Yeah.
And unfortunately, changing your diet and lifestyle isn't one of them because they don't have time to coach that patient. They can just write a script. And if you venture outside of that, then you're practicing outside the standard of care, and now their license is at risk. So they're almost handcuffed. And it's the system that's broken. It's not the docs. And, I taught future physicians in medical school for a number of years. And the curriculum in which we train and teach future physicians is broken.
Yeah, right on this.
Because you learn your biochemistry, your physiology, your first year anatomy. Second year you learn pharmacology. Then you start your clinical rotations. You learn billing, CPT codes. And then you forget all the basic science you learned in the biochemistry. And that's why we created this whole concept called restorative physiology. Because medicine is based on pharmacology, right? Making a synthetic compound that inhibits a biochemical reaction that you can patent and treat a symptom. What I try to do as a biochemist and physiologist is understand the mechanism of disease to the extent that you can fix it. And when you do that, that's called restorative physiology. The principles of medicine that go back, Western medicine, several hundred years, were the principles of applied physiology. That's how medicine was started. And it was basically integrating kind of the Eastern approach of medicine and integrating that into what's called Western medicine, but it was applied physiology. Now Western medicine is just applied pharmacology. There's no consideration for physiology. That's why we have the sickest population on the planet.
Yeah, we do. I love carnivore. You know, I'm not 100% carnivore, but I do really well with meat. You're a Texas guy. You love meat too.
Absolutely.
But we know that there is a lot of hate that vegetables get in the carnivore space. And it's anti-nutrients, oxalates, lectins. And I understand that, especially with somebody who has intestinal permeability.
Right.
Like remove it, fix the gut. Then I think bring it back in. Some people say remove them forever, but they kind of forget the hormesis principle. But this chapter is titled Why Vegetables Are Good for You. So explain the role of vegetables as it relates to nitric oxide, sure. Some of your favorite ones and some of the ones we should avoid.
Well, going back probably hundreds of years, it's known, there's some pretty solid evidence, and this is work by Caldwell-Esselstyn, of a plant-based diet reversing coronary artery disease. So he would take patients who had advanced coronary artery disease, put them on a plant-based diet, and in some patients he would see almost complete regression of disease. So for us, as a biochemist, I take important observations like that and try to understand how can we take that really interesting observation and assign a mechanism of action to it, right? Because then if we understand the mechanism of action, now we can design specific protocols or products or drugs to recapitulate that mechanism of action. So we found out, and for years people thought, well, it was the vitamins, minerals, antioxidants in plants or vegetables that afforded the cardioprotection and the reversal of disease. Well, we and others discovered what is the nitrate content in the vegetables. So dark green leafy vegetables are high in what's called inorganic nitrate. And nitrate is what's assimilated in the plant from the fertilizers. So we can add potassium nitrate, we can add ammonia, we can add nitrogen-based fertilizers. The soil uses that, the plants assimilate it, and it allows for the transport of other nutrients. So nitrate is inert in humans. But when we consume these vegetables, 90 minutes after we consume them, the nitrate is taken up in the gut, concentrated in our salivary glands. And now each time we salivate for the next 6, 8, 10 hours, we're secreting nitrate in the mouth.
If we have the bacteria to do it.
So nitrate is inert. So then we identified some nitrate-reducing bacteria on the dorsal part of the tongue that reduce nitrate to nitrite and nitric oxide. Huh. So now, if we have these bacteria, they perform that 2-electron reduction of nitrate to nitrite. Then we swallow our own saliva, which is now enriched in nitrite. And the pKa of nitrite is 3.4, meaning at pH 3.4, nitrite becomes protonated and it makes nitric oxide gas. So now when we swallow our own saliva, we're getting nitric oxide gas produced in the lumen of the stomach.
Interesting.
And that nitric oxide that's produced in the stomach from swallowing our saliva kills things like H. pylori, the ulcer-causing bacteria. It'll kill things like E. coli, salmonella, botulism, any bacteria that may be on the food or the vegetable you're eating. It's killed very effectively by that process. So now we had a mechanism that you could eat a plant-based diet, restore nitric oxide production, and actually reverse cardiovascular disease. But what we're finding is, and this was kind of, I've had a number of conversations with Dr. Esselstyn, was not all his patients responded. Some got better, some didn't. And we explain that now because, and we published this in 2015, there's high variability in the nitrate content of vegetables. So there's no way to predict how much you're going to get from eating kale or spinach or arugula or celery. Depends on where they're grown, how they're grown, when you consume them. The other issue was you got to have the right oral bacteria. So if you're using mouthwash, 2 out of 3 Americans use mouthwash, you're not going to get the nitric oxide benefits of that plant-based diet. So you're not going to get any improvements in your clinical condition. And then the other issue is people on antacids completely shut down nitric oxide production.
How many people take antacids, do you know?
Well, there's 200 million prescriptions written in the U.S. every year. That's just the number of prescriptions written. That's not counting the over-the-counter, because you can go to a drugstore now or Walmart or Walgreens or CVS and buy Prevacid OTC or Prilosec or Nexium without a prescription. So I think it's the majority, probably 75-80% of the U.S. is on some type of antacid.
You wonder why heart disease is the number one killer.
To me, it's no wonder why cardiovascular disease is the number one killer, because everything we're doing is shutting down nitric oxide production. And I think that's why we have to empower people, give them this information, because these are very simple solutions. If you're using mouthwash, stop. If you're using antacids, stop. If you're using fluoride, get rid of it.
A statin,
fluoride-free toothpaste. If you're on cholesterol-lowering medication, get off of it. It's not protecting you. The evidence is very clear. It doesn't protect you from a first event or a subsequent event if you've already had a heart attack or stroke.
So oh my gosh, the number one killer in the U.S. is heart disease, and
That's right.
these, like you said, are
it's around the world.
Around the world, right? And then it's cancer, and then in America, the third is medical mistakes, like mistakes made in the hospital. It's insane. I was looking at, because we live in America, which is an incredible country. I'm so grateful to live here. But there's some pitfalls to living here. Like one of those pitfalls is they allow big pharma to market directly to the consumer. And there are only 2 countries in the world that allow that, the United States and New Zealand. So I don't watch TV, cable TV, but my mother does. Yeah, smart. My mom does, and I have dinner with her every Thursday. So I go to her apartment here in Bay Harbor Islands, me and my fiance, and she's watching her Hallmark or whatever it is. She loves cable TV on her day off. And then the commercials come on, and it's medication, big pharma, fast food. So I looked up some research, and I saw that 75% of all of the advertisements on TV, the commercials, are from big pharma. 75%. 11% plus is from fast food. So you wonder why we're just being bombarded and people think that is the solution. But what happens at the end of the commercial? Side effects may include this, that, and you wonder, how could people take this with these crazy radical side effects?
If people listen to the commercial rather than watch them, nobody in their right mind would take any of these drugs
it's insane.
that are advertised. Because it may be a 30-second commercial, but 20 seconds of those are the listing of the adverse side effects and things that could happen.
I'm glad they have to list them, by the way.
Well, it's not that they could happen. It means that during the clinical trials and the FDA approval, they actually happened.
Yeah.
So they have to disclose that. And so I encourage people, don't watch TV because we don't.
My mom doesn't listen to me. It's her day off, and she's like, I'm going to enjoy myself.
There's no good news on TV.
Yeah, there's not.
So stop watching TV. But if you do, listen to those commercials. And then ask yourself, do I want to have one of these potential side effects from this drug? And for me, it's about risk-benefit. What's the risk versus the benefit? And for me, in most drugs, the risk far outweighs any benefit, right? So for me, the risk-benefit quotient provides a very simple answer. I don't do it. I don't take any of these medications because it's not how the human body is designed. Give the body what it needs. Get rid of the things it doesn't need. The body heals itself.
Well, that's what separates us, I think, from the majority of people. Our premise is different. I just heard from you that we have a premise that the body has innate intelligence. We remove the interference and this inner physician goes to work. Most people have been brainwashed to believe that it's not the body that heals itself, it's this drug or this surgery. So they have a different premise, right? So I think understanding that the body is built to be self-healing, like you said earlier, we just have to remove the interference. And a lot of the time we're doing the interference. And those symptoms are a gift, right? It's the check engine light. Thank God we have this mechanism for the body to show us. Don't mask it up with these symptoms, with these medications, One of those medications, or a few of them, is Viagra and Cialis. And I want to talk about that because I know there are some similarities to what those medications do for nitric oxide, but those are the pros, but what are the cons to taking those sort of medications?
Well, these drugs are called phosphodiesterase inhibitors. They inhibit a specific enzyme called phosphodiesterase, which breaks down a second messenger called cyclic GMP. These drugs were originally developed for things like ischemic heart disease and pulmonary hypertension. Because, let me take a step back and talk about nitric oxide signaling. So when nitric oxide is produced, it binds to an enzyme called soluble guanylyl cyclase. This enzyme converts GTP, or guanosine triphosphate, into cyclic GMP. And cyclic GMP is the second messenger that leads to smooth muscle relaxation and vasodilation. So it was thought if you could enhance vasodilation, you could overcome pulmonary hypertension, you could dilate the coronary arteries, and relieve things like ischemic heart disease. During those clinical trials, one of the number one side effects that was reported from the patients in the clinical trial were really good erections. So Pfizer, being somewhat astute in terms of looking at market size, realized that if we change this and developed an indication for erectile dysfunction instead of pulmonary hypertension or ischemic heart disease, then have a much broader market, the company would make more money. And here we are 25 years later. Obviously, these drugs are very popular. They're effective, but we now know that they only work in 50% of the men in which they're prescribed. So again, another interesting observation that's published in the scientific literature. Now we have to work back and figure out why is that? Yeah. Why are there non-responders to Viagra? And understanding the signaling aspects of nitric oxide, we now understand that. So if you can't make nitric oxide, if you have complete endothelial dysfunction, because you're using mouthwash, poor lifestyle, or you're using antacids, then you don't get any activation of guanylyl cyclase. You don't get any accumulation of cyclic GMP, so there's no substrate for these drugs to work on, right? So that told us, number one, erectile dysfunction isn't a symptom of overactive phosphodiesterase. If it did, then the phosphodiesterase inhibitors would work in 100% of the people, and they would have 100%
That makes sense.
benefit. But if the patient can't make nitric oxide, these drugs don't work. So it told us ED, erectile dysfunction, is a symptom of insufficient nitric oxide production. So now we take that back to the clinic. So now we go from the clinic to the bedside. We model it, go back to the bedside. Now, if we improve nitric oxide production, we improve that whole signaling cascade. We get cyclic GMP produced. Now you get vasodilation. And now these drugs can actually extend that and potentiate the effects of nitric oxide signaling. So we can take non-responders, make them responders if we restore nitric oxide production. And you can actually lower the dose of these drugs to mitigate the side effects. So nitric oxide kind of turns the switch on, and Viagra leaves it on, right? There's no off switch anymore. So that's why you're warned against 4-hour erections, really bad headaches, the blue vision, an unsafe drop in blood pressure. So our body's designed to have some sort of regulation. But these PD-5 inhibitors, you lose the regulation. You turn the switch on, but you're going to leave it on. And so you have to warn, and people always ask, well, what's the problem with 4-hour erection? Well, it leads to necrosis, and your organ will become completely necrotic and dysfunctional, because in erections in both men and women, you get engorgement, right? That engorgement is due to nitric oxide production dilating the blood vessels, so now you get engorgement. And then it prevents the outflow, right? And so that's what maintains an erection in both men and women. So if you're not getting new blood supply in that's fully oxygenated for a period of time, that tissue becomes hypoxic. Over time, it can become necrotic, and then it's non-responsive. You've got a dead organ. So people joke about 4-hour erections, but they're completely, this is a serious, serious problem. And in many cases, you have to go to the ER and with a needle actually exsanguinate the organ to allow for it to get new blood supply and fully oxygenated.
Yeah.
So these drugs aren't really meant to be played with, if you will. There's serious consequences, and you have to understand the signaling aspects and the pharmacology of the drugs to use them not only safely, but effectively and enhance their effects.
That's wild. So if somebody is not producing nitric oxide because they're on mouthwash, they're on these antacids, whatever reason, let's say they stop doing all that because they've listening to this or watching this and they're inspired. Okay, Dr. Nathan Bryan convinced me. I'm going to stop using it. I'm going to start doing some exercise, eating some green leafy vegetables, maybe taking some of your supplements, which we'll talk about. How soon will the body adapt and start producing nitric oxide?
Well, mechanistically, we know from, let's take diet or antacid or mouthwash, for example, because we published on this in 2019. And in this study, we took young, healthy, normal-tensive people who were good athletes, and we just put them on a mouthwash for 7 days, and then after 7 days, we stopped for 4 days and see, okay, what happens in 7 days to their blood pressure, what happens to their oral microbiome, and then after 4 days, what happens? So in one individual, a 21-year-old triathlete, dental student, in 7 days of mouthwash, we made him clinically hypertensive. We increased his blood pressure 21 millimeters of mercury. We didn't change his diet. We didn't change his exercise routine. All we did was give him mouthwash. And we completely disrupt the oral microbiome. We did daily tongue scrapings, and we didn't get, we got probably 95% kill, not 99.99, because these bacteria are pretty resilient. We're using this twice a day. So after 7 days, we made him clinically hypertensive. And then we stopped, and 4 days later, his blood pressure completely normalized. His oral microbiome had completely repopulated. The diversity increased, and his blood pressure came down.
Wow.
So that tells us that the microbiome is extremely resilient. So if you just stop after 4 days, and I think it would probably mirror the same response if you get rid of fluoride. I think 4 days, although fluoride may stay around a little longer than these antiseptic alcohol-based mouthwash. But the body's resilient. As you mentioned, let's get out of the way, get out of its way and let it do its job. So in terms of exercise, 3 to 4 days of moderate physical exercise, people already see an improvement in endothelial function. So the body is really resilient, and if you stop doing what's disrupting nitric oxide production and start doing the things that promote it and stimulate it, the body responds.
How do you test? How do you know if you're producing enough nitric oxide? Didn't you develop some way of testing that?
Yeah, years ago, probably 15 years ago, I developed a salivary test strip because that was the number one thing asked. How do I know if I need nitric oxide? So we were aware of this chemistry that we could pick up in the saliva. I developed a saliva test. It was really the first point-of-care, non-invasive diagnostic for nitric oxide. I tell people it's a good tool to have in your toolbox, but it shouldn't be the only thing you're using, because now we know there's a number of false positives. If you've got, the case was a 50-year-old obese, hypertensive, diabetic with erectile dysfunction.
Yeah, they're not producing enough.
No, and he spits on the test strip and he lights it up like a Christmas tree.
Interesting.
So what's the problem? Well, he has an active dental infection. And now it's a local immune response in the mucosa that's generating a lot of nitric oxide showing up in the saliva. So it's a false positive. And it's a serious false positive, right? Because obviously this guy is not replete in nitric oxide. So really the only way we tell is through a functional device called flow-mediated dilatation. There's a number of these devices out there. One's called the EndoPath, the other's a cardio-grade device. But really what it looks at is the functional response to how well your blood vessels are producing nitric oxide. And we call that reactive hyperemia.
What kind of test is it? Is it a cuff device? Is it a blood test?
Yeah, no, it's a cuff device. So you basically put a blood pressure cuff on your upper arm and you blow it up to suprasystolic level. So you're basically impeding any blood flow into the forearm. And then either you can get an ultrasound or you can use a temperature probe on the end of the index finger. Huh. And then when you release, so you basically occlude the blood supply for 5 minutes. And you're going to get a little bit tingly. It's not completely uncomfortable, but it's kind of like falling asleep on your arm and your arm falling asleep.
A little bit of some tingling.
There's no blood flow getting to the forearm. And then when you release the cuff, the normal physiological response is your body senses this tissue has been out of oxygen for 5 minutes. I need to get there fast. So the blood vessels make a lot of nitric oxide. It dilates the blood vessels. Now we get really efficient perfusion of that hypoxic tissue. But if the blood vessels don't make nitric oxide, you don't get any resultant vasodilation. There's no reactive hyperemia. And that's a diagnosis for endothelial dysfunction.
Interesting. How do you get that test done? Do like chiropractic offices have them clinics, or do you have to go to your medical doctor?
No, I think there are a number of clinics. These are FDA-approved medical devices. They have a reimbursement code. It's used as a diagnostic. So you've just got to find a clinic, kind of a functional integrative practitioner that understands endothelial dysfunction and has these tools and devices to measure it. But it's a very effective and prognostic medical device.
Yeah, that's interesting. I haven't heard of those actually, but I'm curious to use that with some of my students. What's the relationship between glyphosate and nitric oxide depletion?
Yeah, and it's definitely published on this too. It basically uncouples the NOS enzyme. So the glyphosate is a very toxic poison. So number one, not only does it kill the oral microbiome and the gut microbiome, but because the nitric oxide synthase enzyme is what we call a homodimer. So it's two twins that come together that allow for this flow of electrons to oxidize the guanidino nitrogen of arginine into nitric oxide.
Homodimer, you said?
A homodimer.
Okay.
So it's basically two exact twins that come together that allow for this flow of electrons. So glyphosate will completely disrupt this and uncouple the enzyme. And so now you get a disruption in the flow of electrons, and now that enzyme is producing superoxide, which is an oxidant, instead of nitric oxide. So glyphosate, it's a global problem. It's killing the bacteria in the soil, the nitrogen-fixing bacteria. It's destroying the mineral depletion, the assimilation of nutrients into GMO plants that are sprayed with these poisons, and it's destroying human physiology. So we have to avoid that, and it's everywhere. I just read a report. Again, something come across my feed of, in beer, glyphosate is found in like beer. I guess because now all the weed and stuff is GMO, and they're spraying not just the corn and the soybeans, but the wheat with it. So it's everywhere. I mean,
it's in the majority of our rainfall as well.
Yeah,
because the off-gassing or the off-spraying. So the most commonly foods that have glyphosate are GMO foods. So soy, corn, coffee is loaded with pesticides unless it's organic. Wheat. You could look at Europe as an example, right? Italy. When you go to Italy, and you were just in Europe, right? When you go to Italy, one of the things you would notice there that you don't see there that you see here is that there's not a lot of people that are obese and overweight there. Okay. And then you think, okay, is there a whole bunch of gyms here? The answer is no. So what's the difference? They've banned glyphosate. They've banned red dye 40. They've banned all these toxic ingredients way before us. So they're not taking that hit. And you could see how they're much healthier than us in the United States here.
No doubt. Yeah, when I travel internationally, I was just in Zurich and London and been to Italy a number of times. But when I eat the food there, the foods that I avoid in the U.S., like a pizza or a pasta, I can go there and I have no gastric discomfort.
Yeah.
I have no bloating. It's beautiful food. It tastes great. But the other thing I notice is people walk a lot there.
They do.
They're active. I mean, they're walking around, and when I was in Zurich, there are no fast foods. Most foreign countries I go to, there's always a KFC, there's always a Pizza Hut, there's always a Taco Bell, there's always a McDonald's, no matter where I go in the world. In Zurich, I didn't see this.
Really? Pretty impressive.
I mean, there's good quality food there. And I think in a lot of these countries where we don't have the health disparities and the unhealthy population as we do in the U.S., it's not one thing. It's the lifestyle. And if you look at the blue zones where people live the longest, it's a pristine environment. It's free of toxins. People are active. They're laborers. They're farmers, and they eat good, clean food that comes directly from the farm to the plate.
And they have community, and they enjoy their time with their friends and family.
Doubt. It's not the rat race we live here, but it's, I spent a couple of weeks in Peru. I was just in Costa Rica for a week, but you're surrounded by greenery and electrons and natural springs from volcanoes, and you become replete in minerals, and you're just surrounded by energy. I mean, I could feel it. It's palpable.
What's your favorite country that you've been to so far?
That's tough. South America. I spent a week in Peru. I hiked up Machu Picchu and went to 7 or 8 sacred sites. That experience to me was, number one, I did it because I needed that therapy. I needed that getaway. But you're completely off grid, and there's not the luxury of, the basics, right? No 5-star hotels. But what I learned there, number one, I hiked probably 10 or 12 miles a day, up at 10 to 14,000 feet.
Does nitric oxide help with altitude?
Absolutely. Yeah, it helps you adapt immediately. But then when I would come down to the villages, in these town squares, they've got these farmers that have their vegetables and the plants that they harvested that day. The restaurants buy, you go in and you eat it. It was the cleanest food, and I was there for a week, and it completely...
Wow.
I lost probably 6 pounds in 7 days. I felt energy. I was active, but I was eating good food. You didn't see the chemtrails. You're surrounded by nature.
No cell phone towers, 5G towers.
There was hardly any cell phone service.
That's amazing.
But I think I recommend people do that at least, ever so often when you feel like you're just overburdened, overstressed. And that's what I did. I was in LA, and I go, you know what? I need a break. I got on a plane and I flew to Peru and spent a week in Peru, and then I flew to the south of Brazil and spent a week there and finished my book, and it was probably the most therapeutic thing I've done in my 50 years of existence.
That's awesome. I love that. Question on the nitric oxide piece, because we've spoken about this before. We have the people who love methylene blue, and I've had people sit right where you are right now who tout the benefits of methylene blue, and I actually experience benefits from using methylene blue cyclically myself. But I also experience benefits using nitric oxide cyclically. So the methylene blue people, and I'm generalizing here, the methylene blue people do not like the nitric oxide camp and the usage of exogenous nitric oxide. And then the nitric oxide people in general do not like the methylene blue camp. So give us some clarity here, Nathan.
Well, again, we go to the data and understand mechanism of action. And so we have a clear understanding of the mechanism of action of nitric oxide. We have a very clear understanding of the mechanism of action, therapeutic benefits of methylene blue, and they're conflicting. But I think the resolution may come in the fact of dose dependency, right? So methylene blue, we've used this in the research lab for 30 years, and we use it specifically to inhibit nitric oxide signaling. So methylene blue is an oxidant, right? So it'll oxidize the heme iron of guanylyl cyclase. So we used it to interrogate what we call nitric oxide-based signaling, or cyclic GM, SGC-dependent nitric oxide signaling. So if you use methylene blue, it'll oxidize guanylyl cyclase, and then it'll completely inhibit nitric oxide activation of that enzyme.
But you said it's dose dependent, so it depends on how much methylene blue you
right.
use. So a little bit probably won't do that.
Yeah, I think that's the question that needs to be answered.
Okay.
And then now there's data showing that it actually, because guanylyl cyclase, the target of nitric oxide, is a heme protein. Nitric oxide synthase is a heme protein. So same redox potential, maybe a little bit difference in kind of these vicinal thiol groups that maintain some electronegativity. But it'll actually oxidize nitric oxide synthase enzyme and uncouple the enzyme. It'll oxidize BH4, uncouple the enzyme. So it leads to complete inhibition of nitric oxide production. Now the question is, so again, I never argue with data, and I never argue with the clinical benefits of any type of intervention. So once we do that, now we have to work backwards and figure out, okay, how can you explain these clinical benefits and the benefits that you see? And I think it maybe go back to this concept of hormesis, these brief periods of insult or oxidative stress that lead to an upregulation of antioxidant response elements and an upregulation of these antioxidant defense systems. Now the question is, what is that dose? And I don't have that answer.
Yeah.
But I think what's clear, what I would tell people is, I personally would not take methylene blue every day.
Yeah, I agree.
Because it's a known oxidant, and it's an approved drug for like cyanide poisoning, and because it basically will oxidize the heme, so cyanide can't bind to it and completely reverse or irreversibly inhibit cytochrome C oxidase. But is there a hormetic effect? I think probably so. But we're still trying to interrogate that. And I was interviewed by Scott Scher, who's a great physician and a smart guy, and we had that conversation, but trying to figure out where is the happy medium. And so those people, and I'm not anti-methylene blue, to be honest with you. I just probably don't understand it. I understand it certainly from its pharmacological mechanism of action, but is there room for nitric oxide and methylene blue in terms of biohacking? Perhaps.
You wouldn't do it on the same day.
I wouldn't do it the same day. No.
But I know methylene blue acts differently than nitric oxide, but it sounds like they're both hormetic stressors.
Well, I don't think nitric oxide is a physiological, it's an essential, it's a hormone, right? I think you have some hormetic responses that lead to an upregulation of nitric oxide. But nitric oxide isn't inducing a brief period of insult that leads to an upregulation of certain signaling pathways. Nitric oxide, you have to have continuous production of nitric oxide. Now, there's some adaptive signaling aspects of nitric oxide.
You mentioned like with the mitochondria.
Biogenesis, mobilizing stem cells and activation of telomerase and things like that. But nitric oxide we need every day. Methylene blue, I still, understanding the science and mechanism, I can't contemplate a reason why you would take methylene blue every day.
Okay. You do sound more open to it today than you did when we first discussed this. And I know we went back and forth with text messages. So I like that you're open to more of understanding it. But I do think you're right. I mean, methylene blue is something that I would not take every day or recommend it every day. And if I did take it, I'm not taking nitric oxide that day because it sounds like they're opposing it. Wouldn't make sense to do both.
Well, I would say if you take methylene blue, you probably should take nitric oxide.
Oh, really? Okay. So
because you're leading it. So and again, I mean, there's two ways to think about this. Is part of the hormetic effect of methylene blue by acutely shutting down nitric oxide production where you get an adaptive response later on? So if you take methylene blue and you take nitric oxide at the same time, do you eliminate the adaptive hormetic effects of methylene blue because you're eliminating that brief insult?
How do we know?
We don't know.
Yeah, that's the problem.
Yeah. But no, it's interesting questions, and I always welcome a scientific discussion on things because I don't have all the answers. No one has all the answers. But science progresses by having these discussions. And it's like the narrative. The people who are pushing methylene blue have to talk about the negative effects of nitric oxide or else their narrative doesn't fit with what they're trying to do. Now, maybe the narrative needs to change. The molecule's not going to change. The effects aren't going to change. The narrative has to change. So we have to be open enough to say, well, look, here's what we know about this. And, I'm transparent enough to know that everything I've done in my 25, 30 years of academia is related to nitric oxide. But nitric oxide doesn't work in a silo, right? There are things that activate it. It has effects on this. So there are other things that may be working, hand in hand with this. But so I answer in response to its effects on how it's affecting nitric oxide production, how it's affecting nitric oxide signaling. And for methylene blue, the data are very clear. At certain doses, it completely shuts down nitric oxide production and nitric oxide signaling. And everything we've learned over the past 40 years, that's a really bad idea.
Now let's discuss how we discussed already how to get the body to produce nitric oxide. You're going to remove some of the things that are interfering with it. You're going to add in some green leafy vegetables that you can tolerate. From my understanding, there are certain citrus fruits, pomegranate, and different foods that help with nitric oxide. Not too much, like it's very minimal.
What we have to do is we have to recouple the NOS enzyme in the lining of the blood vessels, and we have to maintain a oral healthy microbiome.
Yeah, those are the major.
Those are the main ones. So, taking things like arginine, citrulline supplements, watermelon extract.
It's not going to move the needle.
All that's marketing ploy, and you don't need it. Your body makes
even
enough,
from foods that contain it.
Even from foods. Arginine and citrulline are semi-essential amino acids, meaning that you get part of it from the breakdown of proteins from your diet. But these amino acids are made through the urea cycle. Every cell in the body has the partial urea cycle that recycles arginine and citrulline to make nitric oxide. And the body makes 20 to 40 times what's necessary to bind and saturate the enzyme to make nitric oxide. So taking more doesn't give you more. So I think what we have to focus on is, one, good endothelial function, eliminate inflammatory foods, eliminate sugar, eat a balanced diet in moderation. I think ketogenic is good. I think for some people, plant-based may be good for some people, especially people with overt cardiovascular disease. I think the data on plaque regression is pretty impressive. But I think we need our nutrients from a diverse sources.
I agree.
And we have to get, the foods we eat today just don't provide the nutrients that we need. And so we almost have to supplement basic nutrients. And I get that through like chlorella and spirulina and algae products and humic and fulvic.
Same.
So I think that's because it's clear to me that the foods we eat, no matter how clean we try to eat.
Yeah, they're depleted.
They're depleted.
Yeah, that's just the way it is.
Just can't get enough.
So what would you estimate, and you've done some really cool videos like showing what other products are not doing when it comes to nitric oxide and how they claim that it helps with nitric oxide. But what percentage, if you had to estimate, of nitric oxide supplements out there, what percentage of them don't really do anything? They're just crap.
Probably 95 to 98%.
95 to 98%. Yeah.
And I've tested these, and I don't throw that number out there lightly because
I've
gone to the health food stores, I've gone to GNC and the compounding pharmacies, and
we've shown some videos on our last interview of you testing it. You can follow him on Instagram. What's your Instagram handle?
Dr. Nathan S. Bryan.
Dr. Nathan S. Bryan. He has a lot of videos of you testing these products, showing that it's all just phony baloney. 95 to 98%.
Yeah. So there's main three product categories. There's the arginine, citrulline products that contain most of them contain caffeine, which is a vasoconstrictor, so and typically don't do anything. And then there's the beet products. Mm-hmm. There's a whole wave of beet products, and I've tested almost every beet product out there, and it doesn't do anything except turn your poop and your pee
red.
Pink and red and cause anxiety.
Yeah, right.
So you got to avoid the beets. We make a fermented beet product that we actually concentrate the nitric oxide.
Is it this one?
Called the NO beets. Yeah. So that product actually works, and as soon as you put that in water, it produces nitric oxide gas.
Yeah.
Then there are companies out there selling beet gummies and chews, which, it'd be funny if it wasn't dangerous.
Oh my gosh.
Because, I tell people this because it could kill an entire industry, right? Nitric oxide is critically important, and people tell me all the time, well, you know what? I took a beet product, I see it on TV, and, it really didn't help me. It didn't lower my blood pressure. It didn't give me more energy. And they go, so nitric oxide doesn't work. And I go, no, the product that you took didn't work.
That's right.
It's not a nitric oxide product. So what we have to do is we have to correct the ship and hold these companies accountable and stop marketing deceptive material and being fraudulent to your customers.
I love that you're calling them out.
Yeah, and obviously I haven't made a lot of friends there.
Yeah, naturally, because, you got to call them out. People are spending money on these products. So we're about to take your NO beets.
Yep.
You've taught me that as soon as it dissolves and you mix it, drink it as fast as possible to get the most benefits,
That's right?
So let's try
We're generating NO gas right now.
Let's do it right now. I like the way it tastes, too.
And it was in structured water, right?
And it was in structured water. That's right. We put it in our infinity block here. So that's a better bonus there. So
this product is a fermented beet powder, and you put it in individual sachets because this is a very potent product. And it would be much cheaper and cost effective to put it in a canister and people can self-dose. But human nature is if one scoop's good, three's going to be great.
That's true.
And we have to be very careful with this because this product produces nitric oxide. As soon as it hits solution, it liberates this gas, so you got to take it as a shot. And now we're generating nitric oxide systemically. And so this is a very, very potent product for an energy or pre-workout.
Yeah, great for pre-workout.
Great for pre-workout. Yeah, we put electrolytes in it. We put mitochondrial ATP in it, so it's an incredible product. But yeah, this is the only beet product that I found that actually works. And I got so frustrated with all the products out there that didn't work or deliver. So we were forced to bring a product to market that actually works. And all these others, you can't get nitric oxide in a chew. You can't get nitric oxide in a gummy. You can't get nitric oxide in a capsule. Nitric oxide's a gas. We have to produce it. And we can't give your body precursors and substrates and hope your body can convert it because the reason you're deficient, as we talked about, is you've lost the ability to do that.
Yeah.
So if your body can't make it, we do it for you.
I love it. And then you have the lozenges. First of all, if you're watching on YouTube or listening on the show, you can get the lozenges, which we're going to speak about right now, the beet powders. There's also some amazing skin care products, all at a discount. If you use the coupon code KetoCamp, we'll put a link for that down below in the coupon code. Go check it out so you could experience what we're feeling right now with our nitric oxide flowing through our body.
That's right.
The lozenges, I found myself using that more often than the powders. And I use it a lot with my clients who have high blood pressure.
Yep.
And I want you to explain what's happening, but I see an immediately decrease in their blood pressure when they take it in a matter of minutes. But if somebody has normal blood pressure like me and I take it, I don't see it drop to a point where it's dangerous.
Right.
So how is that working?
Well, again, it goes back to the resiliency of the human body and just the signaling, the regulation of signaling in the human body. So the lozenge is, I think the way you use that is correct. So the lozenge is like your daily nitric oxide support, like your daily vitamin C, daily vitamin D. The beet product is kind of for an afternoon energy pick-me-up or pre-workout. So what I do is I wake up every morning, I take the lozenge. If I work out in the evenings, then I'll take the beet powder right as I'm walking into the gym. So you don't have to take it 30 minutes before. It's immediately active. But the lozenge was kind of the first technology where we created the only person who's ever made a solid dose form of a bioactive gas. So that lozenge, I designed it to have a resident time of about 5 to 6 minutes. So you put it in your mouth, and over 5 to 6 minutes, it'll slowly dissolve. So don't chew it, don't swallow it, just move it around.
Sometimes I'll chew because it tastes good, but yeah, I know I have to wait.
But as it's over that 5 to 6 minutes, we're releasing about 20 to 30 parts per million nitric oxide gas. And so that nitric oxide will be absorbed buccally. It'll bind to glutathione. We can improve increase the half-life from 1 millisecond out to tens of minutes.
Wow.
An hour. So we can see dilation of the carotids within usually 12 to 15 seconds.
Really?
But like me, so we've done this with 24-hour ambulatory blood pressure monitoring.
Oh, you have? Oh, that's cool.
Yeah. So my blood pressure's 118/72. I take a lozenge, it doesn't move. Now, and we've published this in 2012 of a pediatric patient with severe resistant hypertension. And his blood pressure was, I think, 210/115.
Oh, my gosh.
And with a single lozenge, within 4 hours, we brought his blood pressure down to 130/80.
That's awesome.
So the higher the blood pressure, the bigger the effect. If you have normal blood pressure, low blood pressure, it's not going to drop your effect. And again, it's a dose-dependent effect. We know how much nitric oxide the human body makes, and we deliver that in that lozenge. So we're never giving the body more than what it's designed to see or to produce on its own.
This is what it looks like if you're watching on YouTube. That's the lozenge here. Now, I don't take this every day. I take it probably every other day. And here's why, and I want to give me some coaching here. I'm concerned that if I take it every day, my body's going to not produce it endogenously if I do that too often. Is that a concern I should have, or the amount in it is?
Well, it's a valid concern, but not with the way we do it. And the concern is, in the example we use is testosterone.
Yeah.
Right?
It's negative feedback loop.
It's negative feedback, so it shuts down endogenous production. So people use testosterone and get testicular atrophy because your body sees that you have it, so your body's not going to make it on its own.
Testicles are like, oh, I'm done.
Yeah. So with nitric oxide, it's different. So it goes back to the mechanism of action of how we're producing it and how the body senses that. So the best example is nitroglycerin, which are old drugs that were used for the treatment of acute angina for ischemic heart disease patients. And you see that with organic nitrates, and we call this tachyphylaxis. And it's a fancy word for tolerance. So it doesn't shut down. So those types of drugs actually do lead to that negative feedback. So it shuts down endogenous production, and it leads to tolerance development. But those drugs are completely different than what we do here through our nitric oxide. So what we do is we're providing a nitric oxide at a certain flux. We produce certain nitric oxide over a certain period of time. So if your body can't make nitric oxide, then we do it for you. But more importantly is because it's an orally disintegrating tablet, we're restoring the microflora. So most pathogens are sensitive to nitric oxide, so we're killing the bad guys. The good guys use that source of nitrogen to respire, so we can increase the population of the nitrate reducers. And then number 3 is we recoupled that NOS enzyme. So remember when I said that the glyphosate and oxidative stress will recouple that enzyme?
Yeah.
We put components in there that recouple that NOS enzyme. So now we're actually improving the body's ability to make it. And we've got clinical data to show this, that within 4 hours of taking that lozenge, we can improve endothelial production of nitric oxide by about 20%.
That's cool.
So that lozenge accomplishes everything we set out to do. If your body can't make it, we do it for you, and we improve the body's ability to make it on its own.
It's awesome.
So I take it every day. I've been taking it every day for probably 20 years.
Wow.
And, I travel every week. I try to eat clean, but I work out. But I've got the vascular age of a 32-year-old. So I think there's a number of things that I do that probably contribute to that, but I really certainly.
And how are you vascular age of a 32-year-old? Like, how are you testing that?
I do that through CIMT and through what's called venous occlusion plethysmography.
CIMT, is that the test from Europe?
No, it's basically, it stands for carotid intima media thickness.
Okay.
So it's through an ultrasound probe. You can look at the degree of stenosis of the carotids. And so now you've got this huge kind of worldwide database of looking at the progression of carotid stenosis or smooth muscle proliferation, which is the first sign of vascular disease, or hyperplasia. And then you can assign an algorithm and get you a vascular age. There's other methods like glycan age, which is measuring at. You can look at your telomere links. There's different ways to do this.
A funny story on the glycan age. I did their test a year and a half ago, so I was interested in their testing. And what ended up happening was my score came back and it showed that my age was like 89 years old.
Oh, wow. Okay.
And obviously I'm like, something's wrong with this test. I got to speak to like the scientist. So, I'm on the call. I'm like explaining to him, my lifestyle and all that. And he's like, okay, we need to talk to our other scientists. And there's a certain percentage of people that have, I don't know if it's a genetic thing, that test is not accurate for, and it gives a false high, and I'm one of those people, and I'm there looking at the test like, there's no way I'm 89 years old. Yeah. So they actually told me like, this test wouldn't work for you because of, I forget what the reason was, but yeah, glycan age, testing your telomeres, DNA age is another test as well.
Yeah, you can look at the DNA methylation or different histone modifications.
Yeah.
There's different ones. I think there's, certainly they have to be validated. Obviously, I wasn't aware, but like there's false positives and false negatives on every test, no matter what it is.
Correct.
I've been in the nitric oxide field for more than 25 years, have dozens of issued patents, and so my whole kind of motivation and mission was understand nitric oxide production in humans to the extent that we could fix this and develop safe and effective nitric oxide product technology, whether it's supplements or drugs or topical skincare products. And so we've been successful at doing that. And in 1998, when the Nobel Prize was awarded, there were a number of products that hit the market on nitric oxide. A lot of products that contain high-dose arginine, a lot of...
Those are the ones I see all the time, the arginine ones.
Yeah, and so the problem, and that became an issue for me, because as a biochemist, it never made sense to me why you would give arginine to a patient that was nitric oxide deficient. Because arginine is kind of like cholesterol. It's a semi-essential amino acid. Cholesterol is not an amino acid, but the body makes it, and we get it from our diet. Same thing from arginine. The body makes it through the urea cycle, and then we get it from the breakdown of proteins into amino acids, and arginine is one of those constituent amino acids. So we're never deficient in arginine. So giving arginine is like putting gas in a car with a blown-up engine. The car's not out of fuel. The engine's broken. The body's not out of arginine. It's lost its ability to convert it. Now there's studies from 2006, 2011 that if you give high-dose arginine to patients with endothelial dysfunction, they get worse. Higher incidence of heart attacks, peripheral artery disease patients get worse, intermittent claudication gets worse, and their quality of life goes down.
Damn.
So that just shows that you should not be using arginine as a nitric oxide. And then there were other companies out there selling beetroot products, calling them nitric oxide. And, so I have this device, as you mentioned, it measures nitric oxide gas. So there are a number of ways we can test products. You can ingest these products and then look at resultant vasodilation or endothelial function. You can measure exhaled nitric oxide. But what we do, and the basis for my product technology is, if your body can't make nitric oxide, then we got to do it for you, right? You're not out of precursors or substrates. Your body's just lost the ability to utilize those. And it's very similar to testosterone. If your gonads aren't making testosterone, then we got to give it for you, right? But unlike testosterone therapy, I didn't want patients to become 100% dependent upon my product. I didn't want to cause tolerance. That's a very important issue.
Is there a negative feedback loop with nitric oxide like testosterone and other hormones?
It's dose dependent.
Okay.
So what we do here is we wanted to give a dose that would completely recapitulate endogenous nitric oxide production and not lead to tolerance and shut down endogenous NO production.
How did you determine that?
Well, a number of things. We looked at radio-labeled isotopes of arginine infusion, looking at amount of nitric oxide being produced in the lining of the blood vessel in healthy individuals. We looked at the consumption of kind of a healthy diet and how much nitrate or nitrite was being consumed, assuming that you had the right bacteria and the stomach acid to produce it. And so we come up with kind of a total body nitric oxide production that one could ordinarily consume in a day based on exercise and diet. Mm-hmm. And then we dial that in to our product technology. So the beauty about what we do that no one else does is if your body can't make nitric oxide, then we do it for you. And using that nitric oxide analyzer, if we put this beet powder in water, we see nitric oxide coming off. As soon as it hits water, we generate nitric oxide. So when you put that in water, you got to take it as a shot. Because now we're generating nitric oxide, you consume it.
Let's do it now.
Nitric oxide.
That's why we have the cups.
The body.
Let's do it together. I got you one too, Bryan.
And then what happens is...
No, that's going to be for this.
And then what happens is we actually fix the reason your body can't make nitric oxide. So why is that? Is it because you have an uncoupled eNOS enzyme? Is it because you don't have the right oral bacteria? So we give the body what it needs to recouple the NOS enzyme, leads to improvement in endothelial function. We restore the oral microbiome through this enterosalivary circuit, and we basically improve the body's ability to make nitric oxide on its own.
It's brilliant. So have you done tests where individuals maybe use your products for a month or two or longer, take them off, and then measure their nitric oxide levels, and they're just fine, they're actually producing it?
Well, everybody's different, right?
Yeah.
And we live in a very toxic world, and most people aren't complying and doing what they're designed to do, right? So we're exposed to EMF, we're exposed to herbicides and pesticides on the foods we eat, and so every day we're getting insulted with these environmental toxicants that eventually shut down nitric oxide production. So it's good in the fact that we can actually provide a source of nitric oxide, but clinically, every time we've tested this, we move the needle. And so these are made to be single-shot products here, and we did this intentionally because this is a very potent product. And human nature is...
You want to zoom in on this, Bryan, on one of the cameras?
Human nature is if...
Do his side, because he knows what he's doing.
So we developed these as a single shot because human nature is if one shot is good, three's going to be great.
Yeah, right? That's usually my human nature too.
But no, what this is, we've dialed in the perfect amount of nitric oxide here that will improve your performance and generate just enough nitric oxide that you need. So as I showed you in the video, as soon as this hits water solution, we're generating
it was vaporizing a whole bunch of... So we take it as a shot, so we chug it.
And typically, I try to use about 2 to 3 ounces of water, so you can put it in there. I usually use a frother.
I put a little bit too much, huh?
Yeah, I use a frother to rapidly dissolve it, and then bottoms up.
Now, so I use the packets, not every day, but let's say I'm using your lozenges, my favorite, which I use in the morning and in the evening. If I'm doing this and I'm doing this every day, is that too much? Should I cycle off of one of them?
No, I mean, it depends on kind of what your objectives are.
Okay.
Right, so the lozenge is different. I mean, it's the same nitric oxide technology. The lozenge we designed to have a specific resident time. So I designed that lozenge to dissolve over 5 to 6 minutes. You put that lozenge in your mouth, move it around.
As long as you don't chew it. Like sometimes I'll chew it because it tastes good.
But just let it dissolve. So we're liberating a specific amount of nitric oxide over a specific period of time. Because we know that we need a certain flux of nitric oxide that's absorbed, it goes systemic, and we can regulate nitric oxide production and improve perfusion, support normal blood pressure, support normal signaling and metabolic activity. We induce mitochondrial biogenesis through activation of PGC1 alpha. So all the benefits of nitric oxide we deliver through this lozenge. So what I tell people is the lozenge is kind of like your daily nitric oxide boost. Similar to you take a vitamin D or a vitamin C. This is your daily NO support. The beet powder we developed specifically for pre-workout and for energy. Because beets are kind of the hero vegetable over the past 10 or 12 years, and it's been used throughout most professional sports and NCAA programs. But number one, most people don't like the taste of beets. They're full of oxalates.
Yeah.
And it's a peasant vegetable, right?
Mm-hmm.
So what we did was we took the best part about beets and we ferment our beets. So we pre-convert them so it's not dependent upon the bacteria. And we take the beet pulp out, we take the oxalates out, and we take the beet taste out. And we put electrolytes in there because most people are dehydrated at the cellular level.
Yeah.
And we put mitochondrial ATP in here, a patented product. So if you have mitochondrial dysfunction, you can't make ATP, we do it for you. If your body can't make nitric oxide, we do it for you. If you're dehydrated at the cellular level, we provide the electrolytes to allow for cellular hydration. And it doesn't look or taste like beets. It's a great mixed berry flavor.
Yeah, tastes great.
And it's not the mess you see with beets.
I love it. Brilliant.
And then the other, I think, important placement of this product is to replace things like 5 Hour Energy, the Monster drinks, the Red Bulls, these dangerous
chemical shitstorms,
stimulus-ridden, very dangerous energy drinks that hundreds of millions, if not billions of people are drinking. I want people to get a natural energy source. This is natural energy at the biochemical and cellular level. And what is energy? It's the ability of the mitochondria to produce ATP.
Yeah.
We provide it in this product. We provide the nitric oxide that leads to mitochondrial biogenesis, recouples the electron transport chain, and you get more efficient energy production at the cellular level.
And I remember with the lozenges, you were telling me what it does to lower blood pressure.
Yep.
And you were telling me that it's unique in the sense that if somebody has high blood pressure and they take one of these NO lozenges, it'll lower it, and you could test that with the blood pressure cuff. Right. But it doesn't lower it to the point where it could get to low blood pressure, like if they were on blood pressure meds and they took this as well. Is that correct?
That's right. So I'm always kind of the first guinea pig. Right?
Yeah, I get that.
I experiment myself before I do anything in terms of bringing product to market. So I exercise a lot. I'm in decent shape for my age, but my blood pressure runs 118/72. So really good blood pressure. So if I put a blood pressure cuff on, and we've done 24-hour ambulatory blood pressure monitoring, I take a lozenge. It doesn't dip my blood pressure to, say, 100/60. It causes syncope and low blood pressure and things like that. So what it is, it's regulatory in nature, right? And so even people with hypothyroidism who have maybe a blood pressure of 100/65, it doesn't further drop their blood pressure. And that's a very important safety consideration.
Yeah, very important.
But the other extreme example is we published on a 15-year-old kid with a rare genetic disorder back in 2011. He had blood pressure of, I think, 215/115 when we saw him. And there was no prescription medication that would lower his blood pressure. We gave him the lozenge. His blood pressure within 10 minutes dropped 40 millimeters of mercury. Within 4 hours, it dropped 80 millimeters of mercury.
That's
completely
incredible.
normalized his blood pressure, 120/80, just with this lozenge.
That's incredible. Oh my! And you have some sports teams that use your products, right?
That's right. We have probably over 120, 150 professional and NCAA programs that used our nitric oxide product technology.
It makes sense, right? It's going to give you an advantage, and it's not.
It improves performance from every biochemical and cellular aspect we understand about performance, whether it's athletic performance, sexual performance, or cognitive performance.
When you made those videos testing the other companies, did you have any other companies reach out to you, or some people hate on you for doing that? I imagine you did.
Yeah, I'm a target of a number of lawsuits because I like to speak the truth. And it's a very expensive enterprise here to defend yourself. But, the number one thing is we have to maintain the integrity of the nitric oxide space. There are many pioneers that came before me that built this entire industry, and so we have to preserve the scientific integrity of it.
Wasn't the Nobel Prize awarded to?
That's right, in '98, and the 3 U.S. scientists, and there's been others that have contributed greatly to the field. So these guys kind of discovered the production of nitric oxide in humans, and I was the first to bring a nitric oxide product to market that actually generated nitric oxide, not these other so-called companies, so-called nitric oxide companies. So the whole deal was, and I get these emails all the time, and I talk about nitric oxide. People, when they watch our podcast, and say, well, I took nitric oxide, but didn't see an effect.
Mm-hmm.
And to me, that's very dangerous because it could kill the entire industry. And when I question people, they go, well, I bought this beet gummy that's advertised on TV and said nitric oxide, so I took it and nothing happened. Well, see, to me, that's very dangerous because these products do not generate nitric oxide. And these companies out there advertising and marketing as nitric oxide is deceptive, it's fraudulent, and it's dangerous.
Mm-hmm.
So my objective is to hold them accountable and show that if your product doesn't generate nitric oxide, I'm going to test it. I'm going to prove to the masses that you're fraudulent and you need to be careful and meet the rigor of the science. And I think there's two camps out there. There's companies who just don't know. There's some really good companies out there that make a nitric oxide product, and they just don't have the expertise on their advisory board or their product development team to say, okay, here's the underlying biochemistry, here's what goes wrong, and what people that can't make nitric oxide, and here's how we fix it. They just read some literature and go, oh, arginine, citrulline, some antioxidants, we'll put it in there, we'll call it nitric oxide. So that's naivety, and education cures ignorance, right?
Yeah.
That's our job. Then there's companies that are deliberate in their deception and their fraud. They know that these products don't generate nitric oxide. They're still out there marketing and telling people and trying to convince people to buy their products to basically build company profit at the expense of the consumer. And that's what we do is different. That's why I started these new companies and I run these companies. The scientist is the CEO. So my objective is much less on company profit, but making sure that we bring safe and effective nitric oxide products to market. If we make money, great. But more importantly, the benefit I get from this are the hundreds of emails, phone calls, and texts that I get every day, every week, that we've changed people's lives. And to me, that's gratifying enough.
Yeah, well said. Yeah, respect. Those companies that knowingly, they know that their product is not good, but they still market it as such. They're no different than big pharma, right? They're just
right.
looking for the profit. You also have some skincare products. So there's this right here that I've been using. Yeah. So how does nitric oxide help with skincare, wrinkles, et cetera? And let's do a little bit of a experiment with this.
Well, once we understood that we could make nitric oxide, then I thought, what else could we do? And this goes back probably 10 or 15 years. And it was a personal story for me. My dad's a paraplegic from a car accident in 1984.
Oh, wow.
So I've been dealing with decubitus pressure ulcers on my dad for most of my adult life. And he had a lot of non-healing wounds. And so one of his wounds on his right, he had a right ischial ulcer that wasn't healing. So I started making a topical nitric oxide, a gauze that I could infiltrate with nitric oxide gas, put it in the wound. We could increase blood flow to the wound. We killed infections and the wound healed. And I go, wow. And even his wound care docs go, holy.
When was this? What year was this?
This was probably 2014.
Wow. Is your dad still alive?
My dad's still alive. He just turned 75.
Wow.
He's been in a wheelchair since 1984.
Wow.
So a remarkable guy. So that told me that nitric oxide topically would be a very important technological advantage. And so we're developing this as a topical drug for diabetic ulcers and non-healing wounds. But first we thought, well, the skin is an organ.
Yeah.
Right? Just like the heart, just like the lungs, just like the sex organs. Without sufficient blood supply, that organ fails. So what happens? You lose hydration, you lose collagen, fine lines and wrinkles appear, you start to get acne, you get age spots, and you look old. So what if we could restore nitric oxide, restore perfusion, improve cellular turnover, improve collagen deposition by delivery of nitric oxide gas topically? So that's what I did. I set out and I developed a dual chamber nitric oxide product here, and this is a skincare and beauty product.
So I've been doing, so let's go. We're going to
do a demo here. So it's 2 chambers. So what we do is we apply 1 pump from one side, 1 pump from the other, and when we mix these 2 ingredients together, we're going to generate nitric oxide gas. So you'll see 3 things here if the camera can zoom in. You'll see it bubbling. That's nitric oxide gas being produced. And you'll see it turn pink wherever we apply it. So it's recruiting capillaries and causing an increase in perfusion.
Interesting.
And then you'll see these veins dilate. So we're actually dilating the blood vessels of wherever we apply this.
Yeah, I see it bubbling too.
Yeah. And so what happens here when you improve nitric oxide, so ordinarily we'd put this in the palm of the hand.
On the face, that's what I've been doing,
Yeah, and then rub it together. But for demonstration purposes, we just apply it here. So you can see everywhere we've applied this, it'll turn pink. So now what does that mean? Now we have 5 published clinical trials on this. In 30 days use, we can improve collagen deposition. We improve hydration.
Really?
We improve the tone, texture, clarity of the skin. We've got clinical trials on acne, scar remediation, fine lines and wrinkles. This is a new product category in skincare.
That is super cool. You know what's interesting? Yeah, I could see it. Look,
Yeah, see the veins dilate?
Yeah, look at the veins there.
And look, and the problem I have in skincare is obviously this is a multi-billion-dollar a year industry. But most skincare products are designed to hide or mask the blemishes.
Yeah, right.
Hide the fine lines, hide the age spots.
Root cause, yeah.
What we do is get to the root cause. So we improve blood flow, we improve cellular turnover, we get new cells that are replacing the old cells, we get collagen deposition, tone, texture, and clarity improve. And I mean, the skin, really transformative results in just 30 days. I
want to share some anecdotal shares about your product with my autoimmune. So I have Raynaud's, which is an autoimmune syndrome, a condition. Over the years, my Raynaud's has improved tremendously. A few years ago, 5 or 6 years ago, I would get flare-ups almost every day. That's when I had a lot of mercury issues, mold issues, and I took care of that. And it's improved, but it's not to the point where it's completely gone.
Right.
So if I get usually a mental stress sort of thing might flare it up, where my fingers start to lose the blood flow and turn white. It might happen now maybe once every other month. Before it was like every day. But as soon as I take a lozenge, it goes away. And I have some students who have Raynaud's, and I tell them, look, when you get a flare-up, take a nitric oxide, one of your NO lozenges, and they've told me the same thing. It goes away. So what's happening there? I know the blood, vasodilation, but explain a little bit more.
Well, Raynaud's it's a microvascular disease. Mm-hmm. So it's microvascular dysfunction, meaning that the small blood vessels of the extremities don't dilate or become responsive. So they're chronically constricted, and it restricts the blood supply to the extremities. So what nitric oxide does when it's delivered systemically is it goes and opens up the microcirculation. So now we're opening up those, leading to vasodilation. We perfuse the digits, and you get the color back, and the symptoms of the ischemia and the Raynaud's syndrome go away within a period of minutes.
So important, because if you don't take care of the Raynaud's, it leads to devastating, like scleroderma.
And it's the same thing. If you've got microvascular dysfunction in your extremities, you've got microvascular dysfunction in every other organ. It's a systemic disease. It just manifests in the hand.
Correct.
Same thing. If you have erectile dysfunction or endothelial dysfunction in your sex organs, it's not isolated to that vascular bed.
Yeah.
You've got endothelial dysfunction in the heart, in the lungs, in the kidneys. It's a systemic disease. So we call ED a canary in the coal mine, and I think Raynaud's could be a microvascular canary in the coal mine as well. That particular vascular bed is dysfunctional, and it's not isolated to the extremities.
Yeah, that makes total sense. You have a new book coming out. I don't know if you could share details about it.
Sure.
Okay, so share some details about your new book and what it's called, the title, and then the release date.
As you mentioned, I've written several self-published books. I've written a number of medical textbooks. I've published over 100 scientific papers in the medical literature. But what I find is most people don't read the medical literature. These books are kind of educational and I think entertaining.
Yeah, it's an easy read.
It's an easy read.
For the average person.
But I think our next objective was we went out and we pitched this to some major publishers. My agent got the major publisher on board. But this book will be out. In fact, I'm finishing up the final touches on this book just this week. It's called The Secret of Nitric Oxide, Bringing Nitric Oxide to Life.
Love it.
And the purpose of the book is twofold. Number one, the main objective is to educate awareness around nitric oxide so that people understand how important this is. We go into really great detail, kind of like we did today, on what are you doing that's disrupting nitric oxide production, what's been clinically proven to promote and stimulate nitric oxide production, and kind of bringing all this full circle. But, over the past 25 years, I made a number of really seminal discoveries in the field that really changed the way we thought about nitric oxide. So it's somewhat autobiographical, and it talks about kind of my personal journey and the discoveries we made, the observations we made, how we had to pivot, change the way we thought about nitric oxide, and these other observations that really gave us the information we needed to develop some innovative product technology that, unlike any other company or person, has been able to develop over the past 30 years. So that's the whole point, is kind of tell my personal story, but more importantly, talk about the importance of nitric oxide so that the readers and the consumers understand the information is out there to empower individual patients. So you don't have an excuse for being sick anymore. And our objective is to give people the information they need to empower them to where they never have to see a physician.
Yeah.
That's our goal. And with these types of platforms and podcast and books, we can get the information in the hands of the people. We don't have to pay millions of dollars and advertise like big pharma and push bad products like a lot of these companies. We empower the patient, empower the consumer, give them the information they need to take control of their own health and wellness. And if they're sick, they can get well. If they're well like you and I, they can maintain some wellness and never get sick.
I love that. So stay tuned for that book. We'll bring you back for that when it comes out. Last couple things here, and I know I texted this to you a few months ago because one of the docs in my group asked about this question. Methylene blue is very popular, and there's some people out there who teach about methylene blue, and there's some books out there saying that nitric oxide is actually bad for you and what it does to damage the brain and actually interfere with methylene blue. So I'd love if we could just unpack that and just explain what's actually happening here.
Well, first, let me say everyone has an agenda.
Yeah.
Especially, and my agenda is education and awareness. I'm less interested in selling you product. I'm more interested in providing the science and the education behind nitric oxide. So with that kind of disclosure, methylene blue we've used in the research lab for 30 years, and we use it to inhibit nitric oxide-based signaling. So when we use methylene blue in the research lab, it oxidizes soluble guanylate cyclase, the target of nitric oxide production, and completely abrogates or eliminates the signaling aspects of nitric oxide.
So that sounds bad.
No, it's bad. Everything we know about nitric oxide, if you don't get enough nitric oxide or you inhibit nitric oxide signaling, bad things happen. Methylene blue has been used in the research lab for 30 years, specifically inhibiting cyclic GMP-dependent nitric oxide signaling. So I've never understood this. I mean, maybe you can think about inducing some brief period of hormesis or shutting down nitric oxide production, but the American lifestyle, American diet itself does that. You don't need any type of intervention or hormetic compound to inhibit nitric oxide production. Most people are inhibited by their ability to produce nitric oxide. So I don't like methylene blue. I've never taken it. I don't, and the people that are out there selling this are obviously saying bad things about nitric oxide because it's in the literature that methylene blue inhibits nitric oxide production. So they have to change their narrative. And so rather than talking about kind of the dose dependency of methylene blue and kind of the limitations on dosing, and it's probably a dose-dependent effect. Low microdosing may be beneficial. I'm not convinced, and I certainly wouldn't take it myself because I'm interested in optimizing my nitric oxide production because it enhances telomere length, improves mitochondrial function, and improves my own stem cell function and oxygenates every organ, tissue, and cell in the body. I don't want to disrupt that process, and methylene blue does that.
To me, it's that makes all sense. What you just shared makes total sense. But to me, it's like I interview people who talk about methylene blue too. And I have people in my group who use it and they have some great experiences with it. I use it sometimes before red light. I don't use it chronically. So it's confusing even to somebody like me because there's even some research showing the benefits of methylene blue. So you mentioned it might be dose dependent. So there might be a usage for it where you'll get a benefit, but chronic use of it and too much is what you're saying could...
Well, I subscribe to your philosophy here. I don't think doing any one thing chronically is, in terms of these biohacks.
Yeah.
Right? They're kind of to elicit some adaptive effect. Mm-hmm. So I've seen people and I've heard these anecdotal benefits of people with methylene blue. And so I'm not discounting that. I don't argue with results. I argue with the interpretation of results. So there may be a completely different mechanism on the benefits of methylene blue that have nothing to do with nitric oxide.
Got it.
But what I know from my perspective and being in the nitric oxide space for 25 years is we use it as an inhibitor of nitric oxide signaling in the lab, and that is a very bad thing. So the signaling pathway to mitochondrial biogenesis, right, is very well defined. So part of that pathway involves the production of nitric oxide, activation of guanylyl cyclase, increase in cyclic GMP, and that mobilizes calcium, and that turns on these signaling pathways called PGC1 alpha. And then it's that really signaling cascade that allows for the mitochondria to divide. We call that mitochondrial biogenesis.
Is this a stress to the mitochondria? Because ketones do something similar. It stresses it to create mitochondrial biogenesis. Is this also a stress?
Yeah, it's all part of hormesis. Okay. Right? These acute brief periods of stress then tell the body to adapt. And it's an adaptive response because, intermittent hypoxia, brief periods of ischemic, we call it ischemic preconditioning. If you occlude the blood flow to the brachial artery, it protects the heart from injury from heart attack. So what that does is it's a systemic response. It tells your body, I was without oxygen for 2 minutes, and I don't ever want that to happen. So what I got to do is I got to create more mitochondria to create more energy with less oxygen, because I was just deprived of oxygen, and I need to create more blood flow, vascularity. So now I can create collaterals around that brief period of hypoxia or ischemia, and so you get angiogenesis and vasculogenesis. So that's an adaptive response to brief periods of hypoxia. So intermittent hypoxia, whether you can hold your breath for a minute or 2 minutes at a time, that's an adaptive response, and it allows your body to induce these signaling pathways that lead to the upregulation of certain gene products. So that's how it signals the mitochondria, but it also, it's signaling in the effects of, caspase and iron, getting rid of iron from the mitochondria, which induces apoptosis or programmed cell death. And that's what we want. If a cell isn't functional, it needs to commit suicide and basically degrade, and we get mitophagy and autophagy, and we clean up the cellular debris, and we go in and we make a new cell that works properly.
So all that is a stem cell that's created.
All of that is based on the ability of that cell to get a signal and then respond to that signal. So there's two things that have to happen. We have to get the signal, and then the cell has to respond to that signal. And in nitric oxide, there are a lot of things that go wrong. Number one, the primary problem is we lose the signal. We lose the ability to produce nitric oxide, so the cell never gets the signal, never gets to what to do. So in terms of messaging, the clearest example that people get is, and people care about sexual function, right? Because when we become stimulated, the sex organs are not only highly innervated with nerve endings, but it's highly vascularized. So when we get an intimate thought, then that signals the blood vessels in our pelvic region, our sex organs, I need to make nitric oxide to dilate the blood vessels so I can get an erection. And that's the same response in men and women. So the miscommunication occurs when we have these thoughts, but yet we don't get the signal to the sex organs. And the signal is the body can't make nitric oxide because of endothelial dysfunction, so you don't get vasodilation, you don't get engorgement, and you have sexual dysfunction. So that's the signal kind of from here. And you can talk about the cephalic phase of digestion too. Right. When we see food, we get a cephalic response.
Or smell it,
and we start secreting gastric juices, and we start to increase gut motility. That's the signal. But yet if we can't do that and can't make nitric oxide, nitric oxide's one of many important signaling, but kind of my microcosm revolves around nitric oxide. But all of this is getting the signal and then allowing the body to respond to that signal.
Does every man with erectile dysfunction have low levels of nitric oxide?
Absolutely.
Is that one of the first signs?
We call it the canary in the coal mine.
Canary in the coal mine.
There are a lot of things. Well, not a lot of things. There's a very small list of things that cause erectile dysfunction, but primarily it's a vascular problem. Because you can still do hormone replacement therapy. Low testosterone causes low nitric oxide. So if you improve nitric oxide through hormone replacement therapy, still a lot of men suffer from erectile dysfunction, even though you normalize their testosterone. So what we try to teach these clinics is let's restore the function of the NOS enzyme in the endothelium. So now when you replace testosterone, you can activate the nitric oxide signaling pathway through that testosterone. Because testosterone stimulates and activates nitric oxide production, which leads to vasodilation. But if the enzyme that makes nitric oxide isn't functional, you can improve testosterone levels, but you can't activate or stimulate the enzyme because the enzyme doesn't work. So you're still not going to get the vasodilation and the engorgement. So, and to the contrary, you can, to some extent, restore erectile dysfunction simply by giving nitric oxide, but you can certainly potentiate it and make it better by restoring hormone levels as well.
If low levels of testosterone cause low levels of nitric oxide, would increasing nitric oxide endogenously, through exogenous measures, but also endogenously, help increase testosterone as well?
Well, nitric oxide is part of every endocrine gland. So endocrine glands are glands that secrete hormones, right? Like the gonads, the testes, the ovaries, or the thyroid, or really any endocrine gland. So part of that secretory process, again, it's a signal. Nitric oxide is part of that signaling cascade. That part of that is you get nitric oxide produced, it tells that endocrine gland to secrete whatever hormone. And hormone balance is based upon the ability to sense circulating levels of hormones and then be able to respond with increasing outputs of whatever hormone it is. So if we have poor circulation, and compromised blood flow, there's a poor sensing, right? So the thyroid, or the pituitary, for instance, may not be getting a good sense of what hormones are present in that particular sampling pool because we have compromised circulation. So you're not getting a good sample pool. And then number two, if part of the signaling and the secretion of the exocrine gland that secretes those hormones isn't making nitric oxide because of some type of dysfunction, then you're not going to get adequate secretion of those hormones. And then the other part of that is the hormone receptors, have to be free and unoccupied so that the hormone can reach that receptor and then start that whole signaling cascade. So the whole field of endocrinology is very complex, but the human body is complex. So we have to understand at every stage what's going wrong, what becomes disruptive, and then correct it.
So high blood pressure, sexual dysfunction, erectile dysfunction, those are two symptoms to pay attention to with low, which are probably because of low levels of nitric oxide. Anything else that's a common symptom in the beginning?
Yeah, metabolic disease. I mean, 9 out of 10 Americans are metabolically challenged. And
93%.
93%. Yeah, we published a paper, I believe it was in 2009, showing for the first time that nitric oxide is part of insulin signaling. So when insulin is secreted by the pancreas, it binds to the insulin receptors, primarily on fat, liver, and muscle tissue, but really all cells have an insulin receptor. And then that starts this intracellular signaling cascade that eventually leads to GLUT4 translocation, and then GLUT4 binds glucose from the circulation, brings it into the cell, and you clear sugar from the circulation. Well, we were the first to report that nitric oxide is what is the signal that tells GLUT4 to translocate, go to the membrane, and bring in glucose. So if the cell can't make nitric oxide, you still get insulin binding, you still get part of the signaling cascade, but GLUT4 never gets the signal. So we call that insulin resistance.
So the sugars stay higher in the bloodstream. Insulin needs to be called even more.
Yeah, so what it tells the pancreas, hey, I need more insulin because the GLUT4 is never getting the signal because it's not making nitric oxide. So then you get hyperinsulinemia, hyperglycemia, the onset of the entire inflammatory cascade of metabolic disease. And now if you can just give nitric oxide, and we reported this in the paper, that if we give nitric oxide or restore the cell's ability to produce nitric oxide, you can potentiate insulin signaling, you can increase glucose uptake, and you basically improve glucose tolerance, and you improve fasting insulin levels. So you're basically restoring the entire signaling cascade just by the restoration of nitric oxide. And that's one signaling cascade that we've completely elucidated. And there are thousands of biochemical reactions that are probably occurring in that same fashion. We've just focused on the major ones of how is it regulating blood pressure? How is it regulating blood flow to certain regions of the body? Erectile dysfunction is one critical example, but when we're trying to recall memory where we left our keys, we've got to increase blood flow to the prefrontal cortex to recall memory. And we do that through the production of nitric oxide. If you can't make nitric oxide, you have what's called focal hypoxia or focal ischemia. People develop mild cognitive disorders, vascular dementia, and Alzheimer's. It's a blood flow problem.
Let's discuss the oral microbiome and its role in producing certain bacteria that help us convert food into nitric oxide. Explain how that works, and then what is disrupting that?
Well, so what we've done over the past, and I say we, and it's collectively the scientific community, mainly in the nitric oxide field. So we understand that there's two ways the body makes nitric oxide today. There's an enzyme in the endothelial cells called nitric oxide synthase that becomes dysfunctional with age, and we lose the ability to make it. I believe it was in the 90s, the mid-90s, there was a paper published showing that there's a certain class of bacteria called nitrate reducers. These are facultative anaerobes that can produce a source of nitric oxide that can be detected in the expelled gas from the stomach. So that was kind of the first indication that oral bacteria may be involved in nitric oxide production. So now fast forward to our work in the early 2000s where we were doing tongue scrapings of people and trying to culture these bacteria and trying to find out, are there certain bacteria in the mouth that we could culture and characterize that are producing a source of nitric oxide that may be involved in regulation of blood pressure? And so there's probably about half a dozen primary bacteria. And these are facultative anaerobes that live on the dorsal part of the tongue, so back near the gag reflex on the back of the tongue. And they're facultative anaerobes, meaning that if oxygen's present, they'll use oxygen as their primary respiratory substrate. But when oxygen becomes limiting, they'll use nitrogen. And what they do is they convert nitrate to nitrite and nitric oxide. So nitrate is found in green leafy vegetables. It's part of cured meats or sodium nitrite or saltpeter, potassium nitrate. And then the body has a way of recycling this. So when we eat spinach or kale, or the vegans and vegetarians out there, part of the cardioprotective benefits of a plant-based diet are through the recycling of nitrate that's found in these foods. So when we consume these, it's taken up in the gut, the duodenum, and then there's a pathway where it takes it and concentrates it in our salivary glands. This was first described, I believe, in 1978. Wow. And these were cancer biologists at the time that could not understand why the body would concentrate nitrate in our salivary glands, because at that time, the predominant dogma was that nitrate forms nitrosamines, causes cancer. So why would the human body intentionally concentrate nitrate? And now we understand that they're nitrate-reducing bacteria that perform that 2-electron reduction of nitrate to nitrite. Now when we swallow our own saliva, we get a burst of nitric oxide in the lumen of the stomach. That nitric oxide that we get from swallowing our own saliva will kill things like H. pylori, the ulcer-causing bacteria. It'll kill, if you've got a little salmonella or E. coli on your food, it'll kill it. You won't get sick. So today we completely understand the role of the oral microbiome in the production of nitric oxide. So what's clear is that if you do things that destroy that microbiome, it leads to a loss of nitric oxide production and rapid onset of cardiovascular disease.
What are those things?
Mouthwash. 2 out of 3 Americans wake up every morning and use mouthwash.
2 out of 3?
2 out of 200 million, over 200 million Americans use mouthwash. And, there's 2 out of 3 Americans that have an unsafe elevation in blood pressure. And that's not coincidental. So there's a reason we don't take an antibiotic every day for the rest of our life, right? Because it's like an atomic bomb on the microbiome. So it kills the bad guys, but it also kills the good guys. And now we know that the Human Microbiome Project's completely been mapped out. The bacteria that live in and on our body outnumber our own human cells 10 to 1. So we destroy these bacteria to our own demise. So I tell people, and we published on this in, maybe 10 years ago, but when you use mouthwash, you completely disrupt the ecology of the microbiome. Your nitric oxide levels go down, your blood pressure goes up, you develop erectile dysfunction, and you lose the protective benefits of exercise. So the best example is, and again, most people are well-intended, but think about this. We hear a lot in the media about a plant-based diet. And the data on plant-based diets in people with cardiovascular disease and regressing and reversing cardiovascular disease is pretty convincing. And mechanistically, we can explain this.
Because of nitric oxide.
So if you eat a good balanced diet and you get moderate physical exercise, which stimulates and activates nitric oxide production, but if you listen to the commercials, you say that Listerine will kill 99.99% of your bacteria, have fresh breath before you go out on your date, then you've lost the protective benefits of your diet. You've lost the cardioprotective benefits of your exercise regimen simply by using mouthwash.
And you won't have the erection for your date.
And yeah, you may have good breath, but you're not going to be able to perform.
So this is antiseptic mouthwash we want to avoid.
It's anything that's antiseptic, whether it's alcohol-based or chemical-based like chlorhexidine. So anything that's antiseptic, it should be avoided. And I think mouthwash is a huge problem. 200 million Americans every day wake up and do it. The other problem, and maybe even bigger problem, is fluoride. Everybody, I would hope, brushes their teeth every day. And I would guess that the numbers I've seen, 99.9% of Americans use toothpaste that has fluoride in it.
No. You think it's that high?
I think it's that high. You have to search for non-fluorinated toothpaste.
This is true.
And so fluoride is a neurotoxin, number one.
Yeah.
If you read the back of a toothpaste label, it says, if you swallow this, call poison control. It'll give you the 800 number. So it's rat poison. They use rat poison is fluoride because it's such a toxin. But it's an antiseptic. The reason they put the fluoride in the toothpaste is to kill the gingival bacteria that cause periodontal disease and gingivitis. 40, 50 years ago, maybe that was a good idea, but fast forward, And now we understand that they're good non-pathogenic commensal bacteria that are responsible for maintaining good oral hygiene, and fluoride indiscriminately kills everything. And it's a neurotoxin, and it shuts down your thyroid function. So fluoride is a huge problem. It's not only in toothpaste, but it's in most municipal water supplies.
Yeah, that's right. Don't drink tap water.
Don't drink tap water. And why do they put it in there? Because it's antiseptic.
Right.
It kills the bacteria.
Too big.
So when you consume it, it's killing your gut bacteria. It's killing your oral microbacteria. You shower in it, it's killing the ammonia oxidizing bacteria on your skin that's responsible for producing nitric oxide and killing fungus and any type of dermatological issue. So tap water is very dangerous and very toxic.
Wow. Tap water, don't drink it. Fluoride, toothpaste with fluoride, don't do it. Antiseptic mouthwash, don't do it. Let's say somebody is doing it and they stop. How long will it take on average for them to start to get the bacteria back?
Well, we published a paper in 2019 where within 4 days we could restore 4 days of stopping the antiseptic mouthwash. The oral bacteria completely repopulated.
That's great news.
No, that's great. I mean, look, again, the resiliency of the human body is amazing. And these bacteria, if we just give them, there's an ecology in the mouth that, it's a very rich ecology. And the good guys keep the bad guys at bay, right? As long as we have a good, diverse oral microbiome, you won't get gingivitis, you won't get periodontal disease, because the good guys are the cops that keep the bad guys at bay. Now you start destroying that barrier and these biofilms, now the pathogens, the gingival periodontal disease bacteria will start to flourish, and you continue to disrupt that every day by using mouthwash. Now you set yourself on a very slippery slope to periodontal disease, gingivitis, high blood pressure, cardiovascular disease.
Jeez. What else are we doing to deplete nitric oxide?
Antacids.
Antacids. Proton pump inhibitors.
Specifically the proton pump inhibitors. These, number one, these were never approved for chronic use by the FDA. They were only approved for, acute use for gastroesophageal reflux disease. 3 to 5 days, and then you have to get off. But now, you can buy these over the counter. Got Prilosec OTC, Prevacid, Nexium. You can go, and I know people have been taking these for 10, 15, 20 years. And again, the data do not lie. There was a report, I believe, in 2015 that showed that people who had been on PPIs for 3 to 5 years had a 40% higher incidence of heart attack and stroke. It's not increased risk, it's actual heart attacks and strokes. And then in December of this past year, another report came out that people who had been on these for, I think, 4 years had a 40% higher incidence of Alzheimer's.
Wow.
So, I mean, these drugs are not only, they're not effective, but again, going to the risk-benefit. There's no benefit, and what's the risk? Heart attack, stroke, Alzheimer's. They're deadly drugs. They should be taken off the market completely. Vioxx and Celebrex in the early 2000s were causing heart attacks and strokes, these COX-2 inhibitors. The FDA took them off the market for several years, and now there's a black box warning using them because they cause heart attack and stroke. The PPIs are more dangerous. 40% greater increase in heart attack, stroke, and Alzheimer's. So that's a major problem. And mechanistically, we work backwards. So what we do is we take data, take important clinical observations, work backwards to figure out mechanism. Mechanistically, they're completely shutting down nitric oxide production. So if you don't make stomach acid, if you shut down the hydrochloric acid secreting of the pyloric cells, then you don't have stomach acid. If you don't have stomach acid, you can't make nitric oxide in the lumen of the stomach when you swallow your saliva or eat good food. The other problem is it inhibits an enzyme called DDAH. And that enzyme is what's responsible for breaking down a metabolite called asymmetric dimethyl L-arginine, or ADMA. So now you have an increase in ADMA and SDMA, which acts as a competitive inhibitor to nitric oxide production in the lining of the blood vessel. So these single drug proton pump inhibitors completely shut down nitric oxide from both pathways. So now if you've been taking these, your body is unable to produce nitric oxide. And what are the consequences? High blood pressure, heart attack, stroke, Alzheimer's.
Oh my gosh.
You have to get people off antacids. So that's just part of the increased risk of heart attack, stroke, and Alzheimer's. The other thing people forget in terms of gastrointestinal physiology is you need stomach acid to break down protein.
Right.
Without stomach acid, you can't break down protein. So whether we're eating animal proteins or plant proteins, the human body sees those as foreign particles. So when we eat protein, whether it's from animals or plants, our body breaks down those proteins into amino acids. Then we use those amino acids to make human proteins. We don't incorporate animal proteins. We don't incorporate plant proteins. We use the amino acids from those proteins to make human proteins.
And to fuel the mitochondria as well.
And to fuel the mitochondria. And so if you can't make stomach acid, now you have these peptide fragments that are absorbed across the gut. Your body sees it as an antigen, so it creates antibodies against it. It's the basis for foodborne allergies, autoimmune disease. And if you can't make stomach acid, you can't absorb iron, you can't absorb B vitamins, you can't absorb zinc, selenium, chromium, iodine. And these are the nutrients that most Americans are deficient in.
Yeah. I'm laughing, but I don't mean to laugh because I'm thinking about the person who's watching and listening right now, Nathan, and they're using toothpaste with fluoride, using antiseptic mouthwash on a statin and on a proton pump inhibitor. And they're like, oh my gosh, my life just got rocked.
No wonder I'm sick.
No wonder I'm sick. Yeah, chances are you have symptoms if that's you. But we made the case the body is so adaptive and resilient. You start to remove the interference, the body will adapt. The body will start to heal itself. So there's not hope that is lost here. You definitely
right.
have hope. We're just helping you become aware of this. And people think that the reason they have heartburn is because they have too much stomach acid, when in reality, to your point, it's the complete opposite.
Yeah.
And there's an issue with that lower esophageal sphincter, the LES. And some simple things you can do, by the way, are like humming before a meal, getting into a parasympathetic state, taking apple cider vinegar.
Yep.
This will help to repair the acid and also repair that LES issue that's going on there. Anything else that you would add to that?
No, I think you're exactly right. So when the body senses something that's foreign, it will expectorate that, right? So if your pyloric cells can't make hydrochloric acid to break down proteins and amino acids, then the stomach will sense, hey, I've got a foreign particle in here. It's like if you consume E. coli or salmonella or Clostridium, what's the first thing? What are the first symptoms? You throw up.
Yeah.
It's your body trying to go, I got to get rid of this. Something's bad is in my
You start
body. I need
salivate
to get rid of it.
and then you throw up.
Salivate and you throw up. So same thing. If you can't make stomach acid and you have these peptide fragments because of insufficient protein breakdown, then your body sees it as foreign and wants to get rid of it. So it regurgitates it. And then what little acid is there, you start to burn the esophagus and you get reflux disease. But here's what you do. If you take apple cider vinegar and now you acidify the lumen of the stomach, now you can break down those proteins into amino acids. You won't get the reflux. And just use common sense. Don't eat right before you go to bed. Right?
Yeah.
Gravity plays a very important part.
Yeah, that's true.
in this.
Yeah, you don't want to eat and lay down.
No. So, I mean, you're going to get, just by simple gravity, some regurgitation or at least some flow up into the lower esophageal sphincter and cause some irritation. So, I eat my last meal at usually 5 or 5:30 in the evening. Now I've got, 4 hours of complete gastric emptying. Yeah. I don't have anything in my stomach when I go to bed, so there's nothing to regurgitate.
Yeah, that's a good tip.
But no, I think going back to what you said, these people who are, and when I give lectures and notify people of this, you see their jaw drop.
Yeah.
Because this is something their physician isn't going to tell them. But I tell them, look, people get sick for 2 reasons and 2 reasons only. Medicine's become way too complicated. We have to distill it down to the basics. Your body's missing something that it needs, or it's exposed to something that it doesn't need. And if you address those 2 principles, then the body heals itself. So the data are very clear. Most people are deficient in nutrients. Why are they deficient in nutrients? Well, maybe they're exposed to a toxin like an antacid, a proton pump inhibitor, or a statin, or some infection, or some environmental toxicants. So when you remove the toxins from your body, stop taking these drugs, and then do simple micronutrient analysis, figure out what your body's missing, then give that back, now your body, you've given your body what it needs, and your body will do its job. Now we just got to properly fuel it with the right diet, with the right fuel, and get moderate physical exercise, get some sunlight, and live a good, healthy life.
If you enjoyed that conversation with Dr. Nathan Bryan, watch the previous interview where it was a deep dive into nitric oxide more than what we discussed today. Click the video on the screen.
So it's really the holy grail kind of anti-aging medicine and longevity. So the problem is when you lose the ability to make nitric oxide, there are a lot of things that go wrong.